And today we have somewhere around here the other CMS staff, Noelle Manlove, Dr. Hava Sheffield, and Michelle Joshua. We have a very tight schedule today due to scheduling conflict that occurred in the auditorium. Therefore, we will need to strictly adhere to 10 minutes for the clinical presentations and 5 minutes to review the coding options. For each topic, we will not be verbally reviewing the current coding or coding option 1, since coding option 1 is always do not create new codes. We will begin each coding option discussion immediately with coding option 2. We are also, unfortunately, unable to accept comments over the phone for today's meeting in order to keep to our time schedule. We will accept limited audience comments as time permits. We will be posting the slides from the clinical presentation after today's meeting, as well as the links to the live webcast. We will also be posting an update from the September 2018 meeting discussion of the Section X codes on our webpage, since we're unable to accommodate the full discussion at today's meeting. As a result, we will not be proposing any changes to those new technology Group 1 Section X codes at this time, and we will have a separate full discussion at the September 2019 meeting. For those of you that are new to this process, on page 9 of your agenda and handout packet, you'll find a brief overview. Proposals discussed today will be considered for implementation on October 1st of this year. No decisions are made at this meeting. And we encourage the public to submit their comments on proposals for the procedure code topics by April 5th at the address that's shown in your packet. The final addenda for both procedure and diagnosis codes will be posted in June on our website. If you move to page 10 of your packet, the deadline to submit requests for the September 2019 meeting is June 14th, and you can see the addresses for each diagnosis and procedure code topics there in your packet. For additional detailed information about the process, you can refer to the timeline starting on page 6 of your handouts. As I said, each clinical presentation will have a 10-minute time frame. So over to my right, we have Ben, who will hold up a sign when it's your 2-minute warning time. So you want to keep your eye out for Ben to do that. At this time, we're going to go ahead and begin with our first topic on page 11, cerebral embolic protection during transcatheter aortic valve replacement. The issue is there is not a unique ICD-10 PCS code to describe cerebral embolic protection for all 3 branches of the aortic arch, or to differentiate between a dual filter device and a deflection filter device. The requester is considering a new technology application for fiscal year 2021. Now I'd like to introduce Dr. Alexander Lansky.
Thank you very much, Maddie. Welcome, good morning. So I'm going to be talking about the Keystone Heart Cerebral Embolic Protection device and some of its unique features. Before I go into that, I wanted to give you a little bit of background. As we know, TAVR, as indications are going to lower and lower risk patients, what we have seen is actually an increase in the number of TAVR procedures being performed on an annual basis, currently about 120,000 procedures, projected to be about 300,000 procedures by 2025. We're here to talk about stroke. Major stroke in the randomized clinical trials have been relatively constant over time. You can see here in first generation TAVI randomized clinical trials, the major stroke rate was about 4.2%. And in current generation TAVI devices, it's about 3.1. So really not much change over time. What we have uncovered is that major strokes actually tend to underrepresent the totality of strokes that our patients are subject to. And if you include mild, moderate, and severe strokes, you can see that the rates are actually in the range of 15% and above. Furthermore, if you perform diffusion-weighted MRI systematically in all patients, what we have found is that virtually all patients have evidence of cerebral injury based on these lesions detected on imaging. What we also know is that once we detect these lesions, there is a link with subsequent neurocognitive decline. There's a twofold increase in dementia over time, and this is one of the strongest predictors of subsequent stroke, with a threefold increase in stroke rates. The issue with stroke in the context of TAVR is that it's completely unpredictable. We cannot predict this based on diffusion MRI lesion size or location, and despite best efforts, trying to find clinical characteristics that predict stroke has been very difficult. So again, very unpredictable. If you take a look at the pathology of the aortic valves, these are very calcific, and what we know from transcranial Doppler studies is that the greatest time of cerebral embolization is during the placement of the TAVI devices across the aortic valves. The consequences of stroke are devastating. We know that. There is a very high mortality, very high morbidity. Mortality rates are in the range of 3 to 9-fold higher following a stroke. And of course, disability leading to moderate and severe impairment really affects about 40% of these patients following an ischemic stroke. And in a working patient population, which is very relevant as we're looking at indications for TAVR in low and lower risk patients, only about 44% of these patients following stroke are actually able to go back to work. So again, high morbidity, high mortality in this patient population. These are the data from the pivotal trials, partner trial, the core valve trial, again showing a 3 to 9-fold increase in mortality rates. This is from the SIR-TAVI trial. We're looking at an intermediate patient population, simply to point out once again that the stroke rates are constant. It's a 3.3% stroke rate in this intermediate patient population. It is lower following TAVR compared to surgical AVR, but you can see the consequences. The mortality rates are still about 20%, 18 to 20%, following an early periprocedural stroke. What's the patient perspective? Well, for them, a stroke is really a fate worse than death. They're far more interested in maintaining independence and having the ability to have, to be able to have quality of life instead of longevity. So this is critical from the patient perspective. Okay, I'm going to talk about the devices and some of the distinctions between the devices. This is the Sentinel Cerebral Protection System. It's the only one that is currently approved in the United States. It's a dual independent filter designed for embolic debris capture and removal in 2 of the 3 cerebral vessels. It covers the innominate and the left common carotid. It's placed through a right transradial access down the carotid into the two cerebral vessels. The TriGuard device that I'm talking about here today is different in its design. It's designed to cover all 3 major cerebral vessels. It's a deflection filter. As you can see in the picture here, it protects the entire cerebral vascular system, including the innominate, the left carotid, and subclavian. It's positioned from the femoral artery across the arch, and by design is intended to minimize brain embolization. It has very broad applicability with no cerebral vessel limitations and no anatomic limitations. On this basis, we believe that there are good reasons for potentially different outcomes between the 2 devices. This slide really is intended to highlight some of the unique features and comparisons between the 2 devices. The TriGuard 3, again, is a single deflection filter as opposed to a capture filter. It covers all 3 cerebral vessels instead of 2. It is positioned through the femoral artery instead of the radial access down the carotid. So just coming to a little bit of the clinical evidence that we have, this is the DEFLECT-2, a head-to-head randomized study of 83 patients. We followed patients out to 30 days. We demonstrated deployment success in the majority of patients, 94% of patients. Successful positioning in 87%, meaning that it was in position for the duration of the study, of the TAVI, I'm sorry. And we demonstrated clinical efficacy here. You can see reductions in overall stroke rate. This is based on the American Stroke Association definitions. Improvements in cognition based on the Montreal Cognitive Assessment Tool. Improvements in the freedom from ischemic lesions based on diffusion-weighted MRI in all the patients. About a quarter of the patients had complete freedom from any lesions in the brain. And improvements in cognition at discharge that were tracked out to 30 days and maintained at 30 days. This is a patient-level pooled analysis of all the study patients that we have done, once again showing the efficacy with reductions in stroke based on the American Stroke Association definitions, and improvements in CNS infarction detected by diffusion-weighted MRI. This is the design of the ongoing REFLECT IDE clinical trial, and FDA approval is pending. We're going to be looking at safety and effectiveness. So to conclude, stroke in the context of TAVI is unpredictable. The incidence has been constant over time with TAVR, even in lower risk patient populations, and improvements in TAVI devices. TriGuard use is safe and provides complete cerebral coverage with no anatomic limitations. We've demonstrated that TriGuard reduces stroke risk, cerebral injury, and measures of cognition. And based on its unique design features, current ICD-10 PCS codes do not uniquely identify cerebral embolic protection procedures that first protect all three branches of the aortic arch, including the innominate, the left carotid, and the subclavian, nor do they differentiate dual filter capture from single filter deflection devices. So we believe that modification with more granular coding is needed for accurate reporting and outcome tracking of different cerebral embolic protection approaches and devices. Thank you.
Do we have any clinical questions?
Thank you. I'll be quick. I have two questions. First, I wanted to thank you for differentiating between the capture type and the diversion type. So my first question is, when is the device removed? Is it left in for 2 days? Is it removed right after the procedure?
So it's placed, it's the first device in, so it's placed before the TAVR procedure, and it's the last device pulled out after the TAVR procedure. So coverage is there during the entire time of the TAVI procedure. Okay.
And then it comes out
comes out at the end of the procedure.
Immediately at the conclusion of the procedure.
Yeah.
Okay.
Yeah.
So this is probably going to sound like a dumb question, but that won't be my first. But you've diverted any embolic material from entering into the precerebral arteries. So does it just then come back around again? What happens to it?
So a third of the circulation goes to the brain. So irrespective of the device, either devices, about, with the Sentinel device, about 70% of debris goes downstream. Here, the idea is that you're deflecting away from the brain. Of course, the clinical consequences of stroke, cerebral infarction, et cetera, I've outlined, and the debris would be deflected downstream.
No, I understand that. It's just that, does the debris then break down? And
yes, it goes down, okay. Yes.
And so it's not just going to go down to your feet and then come back up again?
No.
Okay,
no.
That's what I understand. Thank you.
Right.
Okay. Are there any other questions, quickly? No? Okay, we're going to go ahead and move to the coding options. In your packet, the bottom page 12, I think it is, on top of page 13, Coding option 2 is to create a new qualifier value for the deflection filter and a new duration value of temporary for using the deflection filter device placed in the aortic arch. A separate code would continue to be assigned for the TAVR procedure. Option 3 is to create a new code in Section X, new technology, to identify the cerebroembolic protection device using the deflection filter and the aortic arch. And you can see we would add a new device substance technology value as well as a new body part. CMS is recommending option 3, as it states in the packet. It's consistent with a former CEPD device that's included in this section, and we believe it would be easy for coders to find, and it allows the requested level of detail to be included in the code. And consistent with our prior discussion with Section X codes, it will allow for future analysis of these codes. Do we have any comments or questions on the coding options?
Nellie Leon, Chisane American Hospital Association. Looking at option 2, the word temporary as an option, it kind of confused me because I didn't realize how temporary, so thank you for the answer to the previous question. But it also doesn't tell me where it's being inserted, and is there a possibility of deflection filters being created in the future for other applications for insertions in other parts of the body?
Dr. Lansky?
Oh, sorry.
That's okay. Could you come up to the microphone, please? Sorry, I should have told you to stay, just in case.
So I would say I'm not aware of any other devices, but having said that, there are devices that are currently being developed in the context of surgery, so they may have a different access than the leg.
Okay, and temporary, you prefer that to something like intraoperative? Because temporary or immediately, generates all these questions, like how long does it have to stay, or?
Yeah, we're always open to recommendations for the terminology with the code, so if you want to include that in your comments.
Okay.
Okay. Yeah, we can consider that. Okay, are there any other quick comments or questions on the coding options? Can I see by a nod of heads, do we have general support for option 2? Okay, how about for option 3? Okay, I see more heads nodding for option 3. Okay, again, we encourage you to submit your written comments. I'm going to turn it over at this time to Dr. Hava Sheffield.
So this is the administration of Tag-Raxo-Fusp ERZS. Did I say that right?
Very close.
Okay. There's currently no unique ICD-10 PCS code to describe the administration of Tag-Raxo-Fusp ERZS injection for intravenous infusion. And I should have said before, I'm on the top of page 14. This is an intravenously administered anti-neoplastic targeted therapy that is comprised of IL-3 genetically fused to the catalytic and translocation domains of diphtheria toxin. There has been a new technology application submitted for FY 2020.
Good morning. My name is Adam Soares, and I'm a medical science liaison for Stemline Therapeutics, here today to present Tag-Raxo-Fusp. The brand name is Elzonris for the treatment of blastic plasmacytoid dendritic cell neoplasm, and going forward will be referred to as BPDCN. BPDCN is a highly aggressive hematologic malignancy, predominantly seen in the male population, and your median age of diagnosis is roughly between 60 and 70 years old. However, pediatric patients have been diagnosed as well with BPDCN. In 2008, the World Health Organization gave the malignancy the name BPDCN since it was determined that the malignancy was derived from the plasmacytoid dendritic cell. However, prior to 2008, you can see that the malignancy had multiple names on the screen. The classic diagnostic signature for BPDCN is the expression of CD123, CD4, and CD56. Your primary sites of presentation is in the form of a skin lesion. The most common is a nodular form, but also may be hyperpigmented or bruisish-like. The other main site of presentation is in the bone marrow in the form of cytopenias. Also, BPDCN may occur as a secondary malignancy, and typically this is seen in patients that have a history of AML or MDS. Prior to 2018, there was no standard of care for BPDCN and no approved treatments. As I said, BPDCN is a highly aggressive malignancy. From a study in 2013 evaluating patients with BPDCN, the authors found that the overall survival was between 8 and 14 months. These patients receive combination chemotherapy. Even in patients that achieved a complete response to combination chemotherapy, their median overall survival was still only 14 months. The treatment goals for patients with BPDCN is to obtain a durable, complete response, and if possible, bridge the patient to receive a stem cell transplant. Elzoneris is a targeted therapy directed to CD123. Patients with BPDCN overexpress CD123, making this an ideal target and an ideal therapy. Elzoneris is a recombinant fusion protein consisting of human interleukin-3 with truncated diphtheria toxin. Upon binding to CD123, Elzoneris is engulfed or internalized into the cell, at which point will inhibit protein synthesis, leading to cell apoptosis. Here is the pivotal phase 1, phase 2 trial evaluating patients with treatment-naive BPDCN and also relapsed refractory BPDCN. The primary endpoint was complete response, described as complete response plus clinical complete response. Secondary endpoints included overall survival and overall response rate. Here, taking a look first at the treatment-naive population, you're looking at the baseline characteristics. The overall theme here is that the patients in our trial represented your typical BPDCN patient. The majority of patients were male, median age was between 60 and 70, and all but one patient had a skin lesion. Now taking a look at the results, 72% of patients achieved a complete response. The median duration of that complete response is yet to be met. Overall response rate of 90% and 45% of patients were bridged to a stem cell transplant. More importantly, looking at the overall survival, as of right now, a median follow-up of 23 months, the median overall survival is yet to be reached, and there are still long-term survivors that are being evaluated. Now taking a look at the relapsed refractory population, you have your baseline characteristics on your left, again, fits your typical BPDCN patient. On the right are the results. 13% of patients achieved a complete response. The median duration of that complete response is yet to be made. 67% overall response rate, and we actually did have one patient bridged to a stem cell transplant. It should be noted that almost half of the patients in the relapsed refractory population received 2 or more lines of prior chemotherapy, and roughly 80% of the patients were refractory to their most line of therapy. Now taking a look at the safety population, in the table are the TEAEs that occurred in more than 10% of the patients that received the approved Elzoneris dose of 12 micrograms per kilogram. The one thing that I do want to point out at first is that this N is 94, much larger than the N that you probably saw the previous couple slides. That is because this is the safety population. In cohort 1 and cohort 2 of our pivotal trial, patients diagnosed with AML were allowed to enroll in the study and therefore were included in our safety analysis. Looking at the all grades percentage-wise on your left, you can see that capillary leak syndrome, nausea, fatigue were the highest percentage all grade. The other thing I wanted to point out is that the median number of cycles of Elzoneris administered to patients with BPDCN was 4. Taking a look at the select laboratory abnormalities, again looking at the all-grade percentages under chemistry, you can see that glucose, ALT, AST increase, and albumin decrease were the highest selected laboratory abnormalities. So based on the safety and efficacy of the pivotal trial, Elzonris was approved for the treatment of BPDCN in adults and in pediatric patients 2 years or older. This approval was on December 21st of 2018, 2 months ahead of our scheduled PDUFA date of February 21st, 2019. Elzonris is administered intravenously over 15 minutes. The dose is 12 micrograms per kilogram. It's dosed once a day, days 1 through 5 of a 21-day cycle. However, the dosing period may be extended up to day 10 in the event that there are dose interruptions. All patients, or before every dose of Elzonris, patients should receive an H1 and an H2 antagonist, corticosteroid, and acetaminophen. Cycle 1 of Elzonris is administered as an inpatient, and patients should be followed for at least 24 hours post last infusion of cycle 1. In subsequent cycles, Elzonris may be infused in the inpatient or suitable outpatient setting. In this case, patients should be observed for at least 4 hours post Elzonris infusion. Elzonris does have a black box warning for capillary leak syndrome, and for that point, we do have dosing and monitoring guidelines within our package insert to obviously prevent when possible, and more importantly, if the patient does develop CLS, how to manage and how to monitor those patients. As expected, this would also be including in our warnings and precautions. We also, in our warnings and precautions section, have hypersensitivity reactions and hepatotoxicity. Also, you can see under adverse reactions, the most common that occurred in our clinical trial. So in summary, BPDCN is an aggressive malignancy, and prior to 2018, there were no standards of care and no approved therapies. Elzonris is a targeted therapy directed to CD123 and is the first and only treatment approved for BPDCN. In the event of time, you can look at the results of the summary here. And in closing, in order to track claims in the inpatient setting, Stemline Therapeutics is respectfully requesting CMS establish a new ICD procedural code for Elzonris. So with that, I'll open up for any questions.
You can stay up here just in case something comes up. Okay, so for our coding options, option 2 was to create new qualifier value Q, tagrax OFOSP ERZS in table 3E0 of section 3 administration, applied to the 4th character value central vein and peripheral vein, and the percutaneous approach to identify intravenous administration of tagrax OFOSP ERZS. Option 3 is to create a new code in section X, new technology, to identify cerebral embolic protection during TAVR using a deflection filter placed in the aortic arch. A separate code is assigned. I feel like this is
Yeah, that's mine. That was
something weird happened with the merge.
Patient.
Oh, thank you. Okay. Option 3 is to create new codes in section X, new technology, to identify intravenous administration of tagrax OFOSP ERZS, and CMS is recommending option 3. Do we have any questions?
Jean Yoder, Leidos, supporting Defense Health Agency. I'm sorry I didn't ask this earlier. A lot of these had, what kind of population would you expect? How many people annually would you anticipate to be starting this?
According to the SEER database, the incidence was 0.04 cases per 100,000 patients. So that's based on the SEER database. And estimates could run between 100 and 450 patients per year.
Oh, okay, thank you.
Is that, okay.
Sue Bowman, American Health Information Management Association. In the interest of time, I'm not going to mention this through all the other rest of the proposals. I'll just say it once. I continue to oppose adding all of these drugs to ICD-10 PCS. I don't think it's an appropriate use of this coding system, and if there is a need to specifically identify a particular drug, I still would support that the NDC codes be used for that purpose.
Thank you. Any additional comments? Okay, thank you. Our next topic is the administration of Venclexta. The issue is there's currently no unique ICD-10 PCS code to describe the administration of Venclexta for the treatment of acute myeloid leukemia, and the applicant has submitted a new tech application for 2020, and I will turn it over to Dr. Hayslip.
Thank you. Good morning. So I'm John Hayslip. I'm going to discuss with you the request regarding Venclexta. So Venclexta is an oral tablet that's an inhibitor of a protein termed BCL2. BCL2 is a protein that in certain types of cancer cells essentially allows the cancer cells to behave as if they're immortal, to make the cancer cell resistant to dying, even when exposed to chemotherapy. Venclexta is an oral tablet that inhibits the protein or blocks the action of the protein BCL2. Venclexta in combination with rituximab was approved in June of 2018 for CLL. And what I'm here to discuss is more recent at the bottom of the slide. In November of 2018, Venclexta was indicated for the treatment of patients with acute myeloid leukemia in combination with azacitidine, decitabine, and low-dose cytarabine. It looks like I'm looking at an earlier version of slides I submitted, or actually slides I worked on. So excuse me if I fumble just a little bit as we go through the remainder of the slides. So as I mentioned, in November, it was actually just a couple days before Thanksgiving of this year, the United States FDA approved or granted an accelerated approval for Venclexta in combination with azacitidine, decitabine, and low-dose cytarabine for AML. And the issue here is currently the ICD-10 codes do not describe the administration of Venclexta tablets. So hopefully, most of you have not had yourself or your family touched by acute leukemia. If you have not, let me tell you that acute leukemia is a very sudden illness. In my practice at the University of Kentucky, I saw many patients who came to us either by ambulance or by life flight. We're a rural state. But acute leukemia is the kind of disease where often you go to bed the night before in relatively normal health and wake up the next day with a life-threatening illness. For patients who are not eligible for intensive therapy, acute leukemia is generally a death sentence, with acute myeloid leukemia median survival being less than a year with the therapies that were available prior to the accelerated approval of Venclexta combinations. In part, it may be asked why I'm here discussing an oral tablet in regards to these codes. Venclexta is a tablet, but the initial care and treatment of most patients with newly diagnosed acute myeloid leukemia occurs in the hospital setting, not because of something particular about how you administer the treatments, but due to the instability and the life-threatening nature of what's happening with the patient at the time that they're diagnosed with acute leukemia. So AML affects just under 20,000 new Americans each year, and the median age at diagnosis is 68 years of age. About half of patients who are diagnosed with acute leukemia are considered eligible for intensive chemotherapy, and intensive chemotherapy allows the patients to enter a treatment pathway where there's a hope for cure for their diagnosis of AML. But just under half of patients are not eligible for intensive chemotherapy, generally due to age or severe comorbidities, and as I described, the prospects for response and the median survival of these patients who are not eligible for intensive chemotherapy is very short. And you can see shown in the box here, about half of these patients are age 65 or older, and so they're in that Medicare eligible population. So on the left, just very briefly, for younger patients who are eligible for intensive chemotherapy, they receive very intensive chemotherapy, and this generally is on a pathway headed towards bone marrow transplant. Bone marrow transplant, for those patients who are able to receive it, can be curative. But older patients or patients with severe comorbidities such as heart failure, kidney dysfunction, liver dysfunction, they're not eligible typically for those kind of therapies. And there's three main therapies that those patients received in the United States prior to the approval of Venclexta, and that's decitabine, azacitidine, and low-dose cytarabine. And as you can see on the screen, each of those therapies has less than 1 out of 3 patients would expect to achieve a remission when receiving the available therapy, meaning 2/3 would not achieve a remission. Venclexta in combination with azacitidine, decitabine, and low-dose cytarabine has received breakthrough therapy designations from the United States FDA. And in part, this is because the combined CR and CRH rates have increased from less than 1/3, less than 1 in 3, to 2 out of 3, so doubling of the remission rates with the addition of the Venclexta tablets. The median time to achieving these remissions with the previously available therapies, so only about 1/3 of patients achieve remission, and of those it often takes 3 or 4 months for that 1 out of 3 patient who achieves remission. With the addition of Venclexta to these standard backbone therapies, the median time to remission is approximately 1 cycle or 1 month of therapy. So these experiences have been generated, the data for the pivotal data for the US FDA label was generated from 2 non-randomized trials that I'm going to briefly overview for you. These patients were all over the age of 60. They were all ineligible to receive intensive chemotherapy. These patients began, as you see in the bottom half of the slide, their treatment where they had a ramp up or a slow dose increase on day 1, 100 milligrams, day 2, 200 milligrams, day 3, 400 milligrams. These are tablets. And after you reach 400 milligrams, then you continue 400 milligrams once a day of Venclexta. And you receive that in combination with either azacitidine or decitabine, which is a subcutaneous injection or intravenous. As I mentioned, azacitidine and decitabine have been prescribed for years in the outpatient setting for AML. So it's not the burden of the administration that requires hospitalization. It's the fact that oftentimes these patients are diagnosed with life-threatening illness. A separate trial combining with low-dose cytarabine had a very similar dose escalation schedule and is received with the common schedule of low-dose cytarabine given as subcutaneous injections. As I mentioned, the CR and CRI rate in combination with azacitidine was found to be 67%, with venetoclax and decitabine 69%, and with venetoclax and low-dose cytarabine 51%. This is 2 to 4 times higher than seen with those backbones alone in historical studies. The combination of venetoclax with azacitidine, decitabine, and low-dose cytarabine is found to be tolerable, and the adverse events are consistent with what's been previously seen in patient population of patients with acute myeloid leukemia. Infection, low blood counts predominate, and most common adverse events. So do I turn this part over to you all?
Do we have any clinical questions?
Does Gene Yoder, Leidos supporting Defense Health Agency, does this decrease the length of stay or otherwise impact the hospitalization?
Great question. So the data that I'm presenting on today come from non-randomized trials. We do actually have 2 randomized trials that are ongoing, and so we'll see from those results. What I can say is that without Venclexta added on, so azacitidine alone, decitabine alone, the median time to remission for those patients who achieve a remission is 3 to 4 months. With the addition of Venclexta, the median time to remission is approximately 1 to 1.2 months. So oftentimes, these patients don't have to stay in the hospital all the way until remission, but they do have to stay in the hospital until you can get some clinical safety, and then they transition to outpatient care, but still with a tremendous burden of transfusion dependence, high risk for infection, all the way until blood count recovery after achieving remission, which only a third of patients were able to achieve. Certainly being in remission leads to being safer, lower return hospitalizations.
Any additional clinical questions? You can stay up here in case. Sure. Okay, so for our coding options, option 2 is to create new qualifier value venetoclax in table 3E0 of section 3 administration applied to the 4th character value mouth and pharynx external approach to identify oral administration of Venclexta. Option 3 is to create a new code in Section X new technology to identify oral administration of Venclexta, and CMS is recommending option 3. Do we have any questions about the coding? Do we have a general consensus for option 2? Option 3? Okay, thank you.
Hi, sorry, I just wanted to make a quick announcement based on Sue's comment. This was going to be part of the fuller Section X update, but I just wanted to inform everyone that the reason that we continue to provide the coding option for the new technologies in Section X for the drugs is that our system operationally is unable to accommodate the NDC codes on a large scale at this time. So that is why we continue to offer Section X. Thank you.
Our next topic is brachytherapy using a unidirectional source. The issue is there's existing ICD-10 PCS codes that describe low-dose rate brachytherapy, do not specify application that uses a unidirectional source, and do not include all treatment sites for which brachytherapy may be used. The CivaSheet brachytherapy device is applied intraoperatively and may be used in treatment sites beyond those described by existing ICD-10 PCS codes. The applicant has submitted a new tech application for FY 2020, and I'm going to turn it over to Dr. Gustafson and Dr. Perez.
Thank you very much. I'm Tom Gustafson. I'm accompanied today by Christy Perez, who will answer all the tough questions. And by way of disclosure, we are both employed in one way or another by Civatech Oncology. I'm a consultant, and she is a regular employee. We're coming today because we see the need for additional codes to accommodate the intraoperative application of brachytherapy in inpatient settings. The Civatech technology, which I'll describe in a moment, introduces the possibility of brachytherapy in treatment sites that have not previously been used or been available as part of the arsenal. And we are coming with a new technology which allows that to happen. The CivaSheet is the technology I was speaking of, is a implantable low-dose rate brachytherapy device, consists of an array of seeds that I will show you in a photograph of in a moment. The isotope involved is palladium-103. These seeds are configured in a organic polymer and embedded in a flexible membrane that is bioabsorbable. There are two sizes that the company now makes available of these sheets. And the key point for clinical application here is this permits the unidirectional application of brachytherapy. So here's a picture of the CivaSheet. The sources, each of which are have gold shielding on one side are embedded in the polymer matrix that you can see in the photograph on your right. You can see that it's sort of wavy in the picture there. It is very flexible. If we had a video presentation, we could show you how it's very easy to move this around. And this enables the surgeon on doing a cancer resection to configure the CivaSheet to the surgical cavity very flexibly. The unidirectional nature is illustrated in the graphic on your left side, showing the degree of radiation that is available as you move off the zero level. It's one-sided, so the gold shielding doesn't prevent all radiation from penetrating on one side, but it brings it down to less than 10% of the rate that is available on the other side. So ordinary brachytherapy seeds, as I described earlier, all you need to do is think about them a little bit. They radiate radiation in all directions. They've been very effective in a number of different cancer applications on solid tumors. But for intraoperative procedures, they have a number of problems, one of which is that they tend to move around as the surgical wound is closed and during the healing process, so that a surgeon may place them in particular points, but the surgeon cannot be confident that they will stay where they are placed. The CivaTech, because of its configuration and shielding, enables the administration of radiotherapy in a unidirectional nature. This is extremely important in circumstances where there are adjacent healthy tissues that should be shielded from radiation. This may be because they've already received a maximum dose of radiation, or simply because they are healthy tissues that need to be protected in the neighborhood of the prostate, for instance. So the biosorbable membrane prevents source movement, and it was designed specifically to keep things where they're supposed to be and aimed in the right direction. There is clinical experience already maturing on this. We're in early stages yet, but it's coming along. We list here some of the advantages that clinicians are seeing. So sort of not just the company's word for it, but what we're hearing from the surgeons and radiation specialists who are using this. One directional, as I've already spoken about, is customizable. The degree of radiation in the seeds can be custom specified. The sheets can be cut on the spot in the operating room and conformed to the shape of the cavity and affixed in place by a variety of different methods. The product is FDA cleared, which would be their dosimetric studies have been completed. I'll come back to that in just a moment. One of the major advantages of the intraoperative application of this is that this procedure can overcome the need for additional radiation post-surgery. So you do it at the time and not have to rely on external beam radiation later, and the whole thing can just stay in place. It does not need, you do not have to have a second surgery in order to remove it. One of the features of the availability of this product is that clinicians are now moving in the direction of new applications, new body systems and new treatment sites that have not previously been susceptible to this. This includes some arteries and veins, vessels in the neighborhood of the liver, and the musculoskeletal system, which has not been usually a subject of brachytherapy, I understand, and several other treatment sites, as is shown here on the slide. Status today, this was cleared by both the FDA and the Nuclear Regulatory Commission back in 2014. That's some while ago. And both of those steps are necessary in the case of a brachytherapy device. One follows the other. The third step that is essentially a practical necessity for widespread dispersion, widespread diffusion of a brachytherapy device or other radiation device is the completion of dosimetric studies, which must rely on the 2 prior clearances before you can get started on them, and the inclusion of the device on the registry maintained by the American Association of Physicists in Medicine, together with the group down in Houston. So registration was completed in May of 2018, and the door is now open for much more widespread use of the technology. Use to date has been admittedly limited. We have 71 cases. This is a growing number. In the time since I first sent the slides to Sheva, we've added 6, so it's coming along. There are clinical trials in progress, including some involving sponsorship from the NCI, in particular relating to pancreatic cancer, which is very difficult to address in any other manner. So use of the CivaSheet to date is shown here in the variety of different body systems where it was used, in use, and one feature here is we're not seeing any adverse events attributable to the use of the CivaSheet. So in the range affected, no events to worry about. So the coding, as spoken of already, already a code for the isotope. There's a code available for the LDR site. And the key to having this used effectively is the unidirectional nature, and so we have applied for a coding solution that would encompass that. So in summary, we recommend the addition of new codes to allow for the specific coding of this technology. That would include the addition of anatomical sites that are not now used for brachytherapy, but which we expect to become fairly widespread in the next few years as this technology diffuses. The company has applied for new technology add-on payments, but regardless of whether the agency agrees to that in their final rule, the need for the codes we think is evident. So thank you.
So for our coding options, option 2, in the radiation therapy section, create new qualifier 1, unidirectional source, applied to all brachytherapy tables for the 5th character modality value B, low dose rate, and the 6th character isotope value B, palladium-103, to identify CivaSheet brachytherapy. In addition, create new 4th character treatment sites, 0 cranial cavity, K upper back, L lower back, P gastrointestinal tract, Q respiratory tract, R genitourinary tract, X upper extremity, and Y lower extremity, and add to table DW1 brachytherapy of anatomical regions to capture additional treatment sites specified by the requester and not currently in the brachytherapy tables.
Jean Yoder, Lido, Supporting Defense Health Agency. What kind of documentation would you expect a coder to find in the medical record? Do you expect that when this particular or any other future unidirectional, would you expect that that will be part of the documentation in the operative report? Where would you expect the documentation for us to find this?
So your question is, what would we expect to find in documentation when this?
Right, the coders are looking, and what kind of documentation would you expect the coders to see? Would you expect the people applying this to put that in their operative? How would we know that this was used?
I'm not a coder myself, so I may be at a loss to answer your question directly, but the availability of the product would be specific for the individual patient, so it would need to be ordered for that patient.
Okay, so it might have a UDIPN, but, okay, thanks.
Perhaps we could discuss this
I
further
know that was
offline.
Linda's question.
This is a coding question. Nellie Leon, Chisane, American Hospital Association. So with ICD-10 PCS, brachytherapy has been confusing for me, and I think I finally understood it. There are two ways of coding brachytherapy. There's one that is in the radiation therapy section, where the modality, the third character, is brachytherapy. There is also a different type of brachytherapy where it could be done with a surgery. You open up the patient, you remove the tumor, and you leave behind brachytherapy seeds. The difference being that the seeds are left behind either permanently or for a long period of time, versus the other brachytherapy is just a catheter with an afterloader, and they shoot radiation for a few minutes. So the difference being that the brachytherapy seeds that are inserted with removal of the tumor, traditionally we've been putting them in the medical surgical section with the root operation insertion, and the device character being a radioactive element. We've done that for recently, where there was a proposal for something called gamma tile, which was left behind, and we used the root operation insertion, the radioactive element. Also, if you look at the device key, if you look up the term brachytherapy seeds, it says to use a radioactive element. So I guess I'm a little bit confused by why this particular proposal is going into the radiation therapy section, because it seems to be more similar to the insertion of other things like the gamma tile, the brachytherapy seeds that are used for prostate cancer or for breast cancer, where the tumor is resected and the brachytherapy seeds are left behind, then the wound is closed, and they either remain until they dissolve or go away, or we also have removal codes to take them out at some point if there's some problems. And I don't know, maybe this is a little more complicated, but I'm trying to kind of understand, because I finally thought I understood the difference between the two brachytherapy codes within PCS, and now this kind of confuses me.
Yeah, thank you. Now, I don't think we'll be able to address all your concerns at the time, but I do encourage you to put those in writing. We did consider both areas just to address that part, and based on the information that's made available at this time now, this seemed to be the better option, identifying the source, and specifically that it's a unidirectional source for the brachytherapy.
Okay, so your decision was made on the basis of the isotope and unidirectional. I'm not opposing having a code
based on what
created for unidirectional. I think that probably merits recognition, but I'm just kind of trying to wrap my head around which section it should go into and what the root operation or modality should be. Because I thought I understood what PCS was doing before with the two options, but now with this, I don't know where I'm at.
Yeah, and we can possibly provide a little summary on the site, because due to the fact that we are restricted to time, we did say that people could submit questions to our mailbox, so we can put a little sheet on our webpage after with certain questions and give a little bit more information.
Okay, yeah, because this would also go against advice that we've published in Coding Clinic in the past, related to sort of how to, well, the one for the gamma tile, when that code was created, we published something in fourth quarter 2017, and we've had questions related to brachytherapy, where it was intrauterine tandem and ovoids, and we struggle with that on the editorial advisory board, and the idea being that, well, yeah, you have this these seeds, but the seeds themselves were not radioactive. And so, there's existing advice.
There's a lot to consider.
Okay, all right,
agree.
thank you.
Thank you, Nellie.
Do we have any other questions? Okay, and option 3 is to create new codes in Section X, new technology, to specify the CivaSheet brachytherapy during tumor resection surgery. And CMS is recommending option 2. Do we have a general consensus for option 2? Not so much. Option 3? Okay. Thank you.
If you're following along in the packet, we're now on page 23. We're going to discuss treatment of unruptured intracranial aneurysm using flow diverter stent. The issue is there's not a unique ICD-10 PCS device value to describe the use of a flow diverter stent that's implanted to treat non-ruptured intracranial aneurysm. This is not associated with a new technology add-on application. I turn it over to Dr. Alexander Kuhn.
I can advance the slides, right?
Yes.
I see it. Thank you. Thank you very much. And I want to thank the agency for hearing this request. My name is Dr. Alexander Kuhn. I'm a cerebrovascular neurosurgeon. To summarize the key points of this presentation, flow diverting technology is a relatively new endovascular technique used to treat cerebral aneurysms whereby the blood flow is diverted away from the aneurysm through the parent artery in order to keep the vessel open but occlude the bulging, growing aneurysm. In contrast to coiling techniques where things are placed actually in the sac of the aneurysm or the balloon to occlude it from the inside the aneurysm sac. There are currently no unique ICD-10 codes to distinguish the use of a flow diverting stent from other stents or coiling implants to treat an intracranial aneurysm. Thus, there's no way to capture resources or track outcomes associated with using this specific flow diverting technique. So we're recommending that CMS establish a new ICD-10 code to indicate aneurysm treatment procedures using flow diverting stents. By way of background, aneurysm prevalence is estimated 6 million people, or 1 in 50 people in the U.S. have an unruptured brain aneurysm in their head. There will be several people in this room who probably have one unbeknownst to them. Women are more likely to be affected than men. That ratio might even be higher than 3 to 2. Intracranial aneurysms are most prevalent in people ages 35 to 60, with most developing after the age of 40. Flow diverting stenting is a relatively new technique or treatment for cerebral aneurysms, and there's currently 2 flow diverting stents that are available that have been FDA approved, one of which is called the Surpass Streamline device, and the other one is called the Pipeline Flex. So to talk about what flow diverting stenting is, actually the word stent is probably a misnomer when you talk about a flow diverter. It's a stent, we think of things that are opening things up, but this is actually a mesh-like device, which is a low porosity tubular mesh type stent that goes through the artery in the brain, and it is across the neck of the aneurysm. We'll have a schematic here. And by doing this, instead of placing something in the aneurysm, it's addressing the intrinsic issue which causes an aneurysm to form. There's a weakness in the wall of the artery which causes this bulge to occur. It's actually not the bulge itself, it's the weakness in the artery. And this, by placing this mesh device, which I'll show an image in a second, 2 things happen. First, flow redirection. Flow into the aneurysm in the form of the pulsatile nature of blood flow is which causes these to grow and eventually rupture. It redirects the blood flow through the normal conduit, the parent artery, to the brain. And second, it allows for a scaffolding for tissue overgrowth. So not only do you get flow disruption of blocking the blood flow into the aneurysm, over time there's neoendothelialization growth where this scaffolding allows the interdigitation of endothelial cells to form a biological seal and provide a curative treatment for this type of for aneurysms. Here's the schematic you see here. Imagine a cerebral aneurysm sitting off the side of a wall, and this is this mesh-like device, which we call a stent because this is what metal devices placed into arteries are typically called, but this is how it works. You can see it's directing blood flow through the artery and not so much into the bulging balloon. By comparison, this is what a classic stent of the brain with a much larger holes. This is used to go back through. We don't go through flow diverters. Here's an example of a classic stent with the larger holes. We place the stent, then we put a catheter through it, and we put coils inside of the sac itself to occlude it from the inside out. In a flow divert procedure, instead of putting the coils inside of it, the mesh-like stent is placed across the neck of the aneurysm, and over time, the aneurysm heals through the 2 mechanisms aforementioned. So the benefits of flow diverting stents are that they're the only devices capable of being standalone treatment. So instead of having to go inside of the sac where this thin-walled balloon, which is about ready to burst inside of a patient's brain, is sitting, we're able to place something in the artery itself and doesn't require entering the sac itself. It diverts blood flow away, creating this hemostasis. It has very favorable long-term aneurysm occlusion rates. And one of the criticisms of endovascular aneurysm treatment of coiling through the years has been the possibility of recurrence. A patient goes in for a treatment and they come out, and a year later they find that their aneurysm is regrowing. This actually offers the ability for endovascular curative treatment, which is why we say long-term. There's reduced procedure morbidity and mortality. Flow diverting stents are the most studied vascular device and cerebrovascular besides stroke devices, particularly in the area of aneurysms. Overall, these studies have shown that compared to endosaccular coiling, they're safer and they offer higher curative rates, which is why these devices have grown to represent somewhere between 30 and 40% of all cerebral aneurysm treatment in 2019. So there's widespread recognition. The societies all recognize that the flow diverting stents are here to stay, and they're widely used for wide neck cerebral aneurysm, everything from the AANS, CNS, the bodies that govern vascular neurosurgery and endovascular neurointervention. So at this point, I will stop and take any questions.
Do we have any clinical questions for Dr. Kuhn? No? Okay, just hang out up here if you don't mind. Stay up here. Okay, we are on page 25 of the handout. Coding option 2 is to create a new device value, intraluminal device flow diverter, in table 03V, restriction of upper arteries, to identify the flow diverter device. Option 3 is to create new codes in section X, new technology, to enable the capture of additional detail for the endovascular treatment of intracranial aneurysm using a flow diverter stent. Do we have comments on the coding options?
James Kennedy, CDIMD. Based on this discussion, is the root operation really bypass rather than restriction? Because what I heard you say is you're diverting the flow of this, and the definition of bypass is altering the route of passage of the contents of a tubular body part. Can I maybe be educated on that, please?
Yeah, the reason why it's not considered bypass is that it's not creating a new route of blood flow. The blood flow route exists through that conduit, the artery. You're placing this flow diverter, it's disrupting flow into the aneurysm sac as its primary function, so to speak. And they call it divert because we're referring to diverting blood away from the aneurysm sac and putting it through the normal conduit. So we're not putting it to a different place inside of the cerebrum like you would for a bypass where you're doing that. I hope that kind of makes sense.
Linda?
Yes. Linda Holtzman from Clarity Coding. I want to note that I sometimes do consulting with Medtronic, which is one of the device manufacturers for flow diverters, and have also worked with Stryker in the past, although I was not involved in this particular proposal. First, I want to thank you, Dr. Kuhn, for being a physician who understands root operation. Well done, sir. I just want to say that I agree with this proposal. I think it's a good idea to differentiate flow diverters. They really are a very distinct form of treatment for aneurysms. So I do agree. I have a minor suggestion on which character to use rather than using F, but I will send that in writing because it's so minor.
Okay,
Thanks.
thank you, Linda. Are there any other comments, questions, or concerns at this time? Nellie?
Similar to the question that was raised earlier, how would the coders see this documented in the record? Would they be using the term flow diverter or any other terms? How will we know that it's a different kind of stent?
I think that's a great question. I mean, the coders who read these procedure notes, that it will be incredibly non-subtle, the fact that this was the way this was being used to treat. Everything top to bottom about these procedures as compared to an endosaccular stent coiling where a stent is used that way is very different, both in the two implants which are used by name, they would be recognized. And the catheters and techniques which we deploy these devices are clearly distinctive from the way in which a stent coiling is performed, whether it be for an aneurysm and even another stent inside of the brain for a steno-occlusive type narrowing or something like that. This is, the operative note will reflect these specific devices and the manner in which flow-diverting stents are deployed.
Okay, thank you.
It's Linda, I'm back. I just wanted to speak to Nellie's question. There's lots of things you can put in the intracranial vasculature. The key issue here would be for coders to differentiate between an embolization stent and a flow diverter. And the embolization stent is used with coils. So it's there to keep the coils in place. So if you're reviewing a procedure report and they're just putting in this device, and there's no intention of doing coils or anything like that, then it is a flow diverter. And of course, the device appendix, or appendix yet, would have mention of that too. So,
Yeah, we have the device key where we would make the corresponding entries. Okay. All right. Are there any other comments? Okay. Thank you very much. CMS is recommending option 2 at this time, and in the interim, you would continue to code as above under current coding. We'll now turn to page 26 of the packet for the topic of renal function monitoring. The issues, there's not a unique ICD-10 PCS code describe measurement and or monitoring of the glomerular filtration rate in real time for patients with impaired or normal renal function in a non-invasive manner. And I'll turn it over to Dr. Stuart Goldstein. This is not a new technology.
Good morning. So I want to give a background on kidney disease. This is a hidden global epidemic. Close to 1 billion people worldwide have some form of kidney disease, and about 10 to 12% of adults have chronic kidney disease, which is defined as a glomerular filtration rate of less than 90 mils per minute. And about 13 million people experience an acute kidney injury episode annually, and this can potentially lead to chronic kidney disease. While there has been a significant improvement in outcomes in patients who have cardiovascular disease and cancer, during the 15-year period covered by this study in JAMA, health loss due to kidney disease increased by 18%. So there is a gap in the improvement for patients who have acute and chronic kidney disease, respectively. A real-time dynamic GFR measurement at the bedside has the potential to improve kidney-related health in ways that I'll discuss in a minute. Currently, clinicians rely on equations that use serum creatinine to calculate an estimated glomerular filtration rate. However, estimated GFR calculations are very poor surrogates for true GFR because it is dependent on the muscle mass of the individual. So patients who have chronic disease and have low muscle mass will have falsely low serum creatinines, leading to an overestimation of GFR. And in the critical care setting, serum creatinine changes to define or diagnose acute kidney injury are significantly delayed. This graph shows the relationship between changes in serum creatinine and GFR. GFR estimates of using serum creatinine are unreliable in patients who have a clearance of greater than 60 mils per minute or above CKD stage 3. As you can see from this graph, serum creatinine does not rise significantly until the GFR is less than 60 mils per minute. And 50% of kidney function loss has to occur before we see a serum creatinine rise. This formula to calculate the GFR or estimate the GFR in patients with chronic kidney disease, called the CKD epi equation, is the most widely used eGFR estimation formula. The solid line shows the estimation formula or the results from that across the wide range of GFR. And while this estimation equation is beneficial on population health, each of the small gray dots show an individual patient in this study. So for a patient whose CKD epi-equation may result in a number or a value of 59 mils per minute, an individual patient may have a true GFR of 30 mils per minute above that, so normal GFR, or 30 mils per minute below that, approaching or exceeding CKD stage 4, going close to CKD stage 5. Therefore, for the individual patient, these estimating equations are highly inaccurate and can change over time. So the transdermal GFR monitoring technology from MediBeacon uses a fluorescent molecule, ramipirazine, or also known as Lumitrace. This molecule is injected by an IV, and a transdermal sensor is placed on the patient's skin. The sensor excites the Lumitrace due to its large Stokes shift. And the only way that Lumitrace is removed is by glomerular filtration. It is not secreted by the tubule, and it is not taken up by the tubule. The transdermal monitor senses a change in fluorescence over time, and after 1 hour, after it's equilibrated in the patient's total body water, a GFR value is established and can be continuously monitored for up to 8 hours in patients with normal kidney function and up to 24 hours in patients who have CKD stage 4. This is a fluorescent tracer. It is not an isotope. Pilot studies have already been completed in 160 subjects who are adults who have normal kidney function to CKD stage 4, and it works over an entire range of skin colors. The FDA has granted breakthrough device status for transdermal GFR measurement for patients who have impaired or normal kidney function, and a multi-site pivotal study is to be conducted in 2019. You can see here the initial pilot data using MB102, which is also another name for Lumitrace, comparing that to the standard Omnipaque assessment using that measurement. And as you can see, there is a near perfect correlation between the GFR by MB102 and the GFR by Omnipaque. The difference is that with transdermal assessment, this can be done at the bedside, whereas a patient does not have to go to a radiology suite as they would with iohexol. So our anticipated uses in the clinical setting are as follows. Patients who have septicemia or severe sepsis, heart failure, circulatory disorders, acute kidney failure, open heart surgery, or transplant procedures are all at high risk for acute kidney injury and rapid changes in GFR, whereas I mentioned before, serum creatinine is a very late marker of changes in kidney function. I'm going to give you two different potential use cases in more detail. One can imagine a patient with heart failure and fluid overload and cardiorenal syndrome. A creatinine may be elevated in that patient. By providing MB102 and getting a real-time GFR monitor and assessment that can be assessed longitudinally, we can use this as a theragnostic. We could determine if afterload reduction causes a change up or down in GFR within an hour, or if improvement in blood pressure with inotropes improves GFR or causes a problem or decreases GFR. Now the physician will have a theragnostic within 1 hour to determine the trajectory of the patient's course and the response to therapy. This could limit hospitalization or accelerate the need for more invasive intervention. One area that's incredibly important is drug dosing on CRRT. CRRT is continuous renal replacement therapy and is the most aggressive form of dialysis that is provided for critically ill patients. Many patients receive antimicrobials for sepsis and other medications that we do not have standard laboratory assays for. And in fact, we do not know how to dose these drugs. In fact, the FDA, ASN, and the Kidney Health Initiative identified optimal drug dosing for these most critically ill patients as a significant gap and was the first project that was funded by the Kidney Health Initiative. And the lack of reliable clinical data for dosing may lead to underdosing of life-saving antibiotics, or may lead to overdosing of chemotherapeutic agents and associated toxicities. This dosing is continuously done on an empiric basis. We tested the hypothesis that we could use MB-102 to be able to assess clearance of medications while on CRT. MB-102 has a molecular weight of 382, and it is not protein-bound or lipophilic in any way. We did initial in vitro studies to show on a CRT circuit that it is completely cleared by the dialysis device. In this experiment, we performed bilateral nephrectomies on pigs. We connected them to a CRT circuit, and then we injected MB-102 once they were on CRT. And we also injected a dose of meropenem, which is a commonly used antibiotic to treat gram-negative sepsis. What you can see here in the solid blue line that goes up and then equilibrates is the MB-102 as it diffused across the pig's circulation. And then we had 4 different clearances that were prescribed continuously. The first one was low blood flow with a low clearance flow known as ultrafiltration flow. Then we increased the ultrafiltration flow to increase the clearance of MB-102. Then we had high blood flow with a low ultrafiltration flow in green, and you can see that the slope of the line decreased. And then when we gave the highest clearance with high blood flow and a high UF flow, and the clearance increased. MB-102 in these pigs, again, the sensor was placed transdermally, so we are looking at transdermal clearance of MB-102. We then looked at the clearance of meropenem, this antibiotic for which we do not have a bedside level in our clinical lab. And you can see across all 4 of the different treatment configurations or prescriptions in CRT that there was a very tight correlation. So if we can prove this in humans, and there shouldn't be any reason we can't, within an hour we can give the bedside ICU physicians, clinicians, and pharmacists an accurate clearance of a small molecule, and we could give them accurate dosing recommendations on which to base meropenem, piperacillin tazobactam, or other life-saving antibiotics. Currently, this device has been used preclinically by over 100 academic centers throughout the world, by more than 25 pharmaceutical companies, and we have over 125 published research articles and poster abstracts. This is considered the state of the art for preclinical renal function assessment. So currently, having a procedure code that would enable physicians, hospitals, payers, and researchers to conduct comprehensive analysis about the utility of this procedure in inpatient care management, including patient outcomes, costs, and other endpoints of interest associated with the use of this novel real-time functioning monitoring is critical. So we request the addition of an ICD-10 PCS code so that hospital coders can accurately report the use of real-time function monitoring in the inpatient setting. Thank you.
Do we have any clinical questions for Dr. Goldstein? Oh, okay. Still stay up here just in case. Okay. All right. We're going to go ahead and move to the coding options on page 28 of the packet. And Jean, go ahead.
Jean Leidos, Supporting Defense Health Agency. Okay, so I right up front, I'm not good at this. I'm trying to understand. So you can have it up to 3 times. 3 times you'd inject this in a healthy patient with normal filtration who you were just monitoring 3 times in one day, right? Because you've got up to 8 hours with the normal glomerular filtration. And then for the patients with decreased filtration, it'd be maybe, up to 24 hours. And so if you're trying to code this, we would code a quantity of 1 for every time we injected the substrate?
Right, so I think that actually is, in your question, is a clinical question. So in a patient with normal kidney function, we would only inject this once. There would be no reason to inject it again. And then for a patient who has delayed kidney function, we would likely also only inject it once in that day. Somebody who has normal kidney function is not going to need to have their kidney function or have this re-administered, because if they, say, get a nephrotoxic, kidney injury toxic antibiotic, the skin sensor can stay on, and we can look for any change in kidney function for up to 8 hours in that patient. So we would not re-administer it in that situation.
You're fine, Jean. Okay, we're on page 28, and coding option 2 is to add a qualifier for other fluorescent substance in table 4A1, applied to the body system value urinary. And this change would enable accurate data for non-invasive monitoring of renal function from a previously administered fluorescent substance. Option 3 is to create a new code in section X for the same reason, except you have the specific fluorescent pyrazine for non-invasive monitoring of renal function. At this time, CMS is recommending option 3 to allow the specific level of detail that's being requested, and again, also to inform future analysis of the section X codes. So do we have additional questions, comments regarding the coding options? Okay. By a nod of heads, I'd like to see if there's any support for option 2. Not so much. Option 3. Okay, I see more heads nodding. Okay, I just noticed on interim coding advice it said continue code is above under current coding, but we currently don't code this in the inpatient setting, so just disregard that. And again, submit your written comments. Thank you very much. At this time, I'd like to turn it over to Noelle Manlove.
Hi, good morning. Our next topic is going to be the administration of caplacizumab, and we would like to have Dr. John Kenter come up. This is going to be found on your handouts on page 29. Currently, there's no unique code to describe the administration of caplacizumab. It is FDA approved and newly on February the 6th, and they currently have a new technology application in place. So with that said,
Thank you. I appreciate your time that the agency has given us for this presentation. I have noted, my name is Jonathan Kender. I do work as an employee of Sanofi Genzyme, and I'll be discussing today caplacizumab for the treatment of acquired thrombotic thrombocytopenic purpura. I'm going to refer to that as ATTP. Today we are here to discuss the current issue for the coding of the ICD-10 PCS procedural code, and that fact that we do not have a unique identifier for caplacizumab administration. A unique ICD-10 PCS code will facilitate the NTAP recognition and allow for appropriate claims tracking to generate data, support further research of caplacizumab use in the resolution of ATTP, and of note, Sanofi has applied for the NTAP for the fiscal year of 2020. As also previously stated, caplacizumab, or Kablivi, was approved for the treatment of TTP by the FDA on February 6th of 2019. And the current standard of care of TTP is a rare, rapidly progressing, life-threatening thrombotic microangiopathy characterized by severe thrombocytopenia, microangiopathic hemolytic anemia, or MAHA, and organ ischemia. Now, despite current standard of care, if left untreated, there's roughly about a 90% mortality rate in these patients if left untreated, with a median time of diagnosis to death roughly about 9 days from claims data. Now, based upon current standard of care, we have seen that there is still roughly a 20% mortality rate despite the best care that could be given. We're recommending that caplacizumab be adjunctive to therapy to current standard of care. What is ATTP? As mentioned before, rare life-threatening blood disorder, reported annual incidence of 4 to 5 cases per million in the United States. ATTP is characterized by the formation of microthrombi in the body's smallest blood vessels, particularly those in the heart, brain, and kidneys. patients develop autoantibodies that inhibit the enzyme called Adams TS13, which cleaves ultra-large VWF, or von Willebrand factor multimers. Von Willebrand is released from the endothelium into the bloodstream, where Adams TS13 normally is cleaved down, or Adams TS13 normally cleaves the von Willebrand factors, and at that case, releasing of the VWF can also lead to platelet adherence and therefore circulating microthrombi. Those can affect the heart, brain, kidneys, in such areas. Current standard of care includes daily plasma exchange, which is used to remove the ultra-large VWF, removes autoantibodies, and replenishes what we have as Adams TS13. Also, current immunosuppression inhibits autoantibody formation. Now, immunosuppression should be administered with current standard of care, plus or minus the use of rituximab as well. Now, despite, as mentioned before, current standard of care and treatment, there's still roughly about 20% acute mortality with a median time of diagnosis, once again, of 9 days. Up to 42% unpredictable refractoriness to treatment and associated with poor outcomes. And up to 50% unpredictable exacerbations. How does caplacizumab work, and how is the proposed mechanism of action of caplacizumab? It prevents further binding of platelet adhesion to TTP in TTT patients by inhibiting the binding of platelets to the A1 domain of VWF. As mentioned before, VWF and A1 domain is where platelets adhere to, which would be causing microthrombi throughout the body in the patients. Following injection, caplacizumab binds specifically to the A1 domain of VWF multimers in circulation, and VWF-bound A1 domain, the circulating platelet strings for the VWF. Now, up to administration. Now, caplacizumab should be administered in the hospital setting initially. Prior to the first plasma exchange, an 11 milligram bolus IV injection at least 15 minutes prior to plasma exchange, followed by 11 milligram subcutaneous injection after completion of plasma exchange on day 1. Subsequently, 11 milligrams of a subcu injection once daily, followed by plasma exchange. Treatment after the plasma exchange period, 11 milligrams subcu injection once daily for 30 days beyond the last plasma exchange. After the initial treatment course, signs of persistent underlying disease, such as suppressed Adams TS13 activity levels remain persistent, treatment may be extended for up to a maximum of 28 days. Now, going to label, discontinue Kablivi use if the patient experiences more than 2 reoccurrences of TTP while on Kablivi. I'm going to take you shortly through our phase 3 trials and just give you a slight overview of them. And this is evaluating the safety and efficacy of caplacizumab in our phase 3 trial called Hercules. These are patients who had received 1 PE plasma exchange treatment and were randomized 1-to-1 placebo. Once again, single IV dose, therefore subsequent sub-Q afterwards. Our primary endpoint here was a time to platelet count response, as shown by a Kaplan-Meier curve here, is that we, at any given point in time, found that caplacizumab is 1.55 times more likely to achieve a complete platelet count response defined as greater than 150 compared to that of placebo. Now, for our secondary endpoints, we looked at ATTP-related death, recurrence of TTP, and at least 1 treatment-emergent major thromboembolic event. We saw that there was a difference statistically significant between a total number of subjects with at least 1 of these events noted between. Secondary endpoint, and I must define the exacerbation and relapse here, is that exacerbation is found on the bottom here, recurrent thrombocytopenia after initial recovery of platelet count that required reinitiation of daily plasma exchange occurring during the 30-day post-daily plasma exchange period. Now, relapse is essentially the same, but after the treatment period and no longer on treatment. You'll see the differences here that on treatment, we saw that 3 patients had experienced a exacerbation, while 6 had experienced a relapse after treatment had been removed from the patient. So why does this matter? What does this mean for the patients and the outcomes that we're seeing currently as one of our other secondary endpoints? We looked at the number of days of plasma exchange, the volume of plasma, number of days in the ICU, and number of days in the hospital. In days of plasma exchange, we saw a 38% decrease. In the volume of plasma, 41%. Days in the ICU, 65%, and number of days in the hospital, 31% reductions. In summary, the addition of caplacizumab when used in conjunction with plasma exchange and immunosuppressants significantly improved clinical outcomes for patients with an episode of TTP when compared to the use of current available treatments, which is plasma exchange and immunosuppression, alone as shown in the Hercules study, by reduction in time to platelet count response, a significant reduction in the composite endpoint of TTP-related death, recurrence of TTP, or major thromboembolic events, and reduction in the proportion of patients with a reoccurrence of TTP in the overall study period. Reduction in the number of days of plasma exchange with a mean length of ICU stay in the mean length of hospitalization. The principal risk of treatment, most frequently reported as adverse events were epistaxis, headache, and gingival bleeding. Supply the indications and important safety information for your note as well. Thank you.
Okay, are there any clinical questions at this time? Okay, I'm going to present the coding options, and they're found on page 31 of the handout. Jump right into option 2. To create a new qualifier, value W, caplacizumab, in table 3EO, section 3, administration, applied to the fourth character values, peripheral vein and central vein, to identify the subcutaneous injection or intravenous infusion of caplacizumab. Option 3 is to create new code in section X, new technology. So, are there any questions on the coding aspect of this presentation? Okay. For option 2, show of nods of heads. Any in favor? Okay, I see a couple. Option 3, nods ahead. Okay, thank you. Thank you, John. Our next topic will be the administration of Contipo, be presented by Dr. Kim Sweeney. It's found on page 32 of the handouts. Okay. The issue is there's no unique code, ICD-10 PCS code to describe the administration of Contipo. They have applied for a new technology application for 2020, and it is not currently FDA approved.
I am not Kim Sweeney. There had to be a change kind of last minute. So my name is Matt Helgeson. I'm one of the medical science liaisons at Nabriva Therapeutics, and I'd like to thank you for your time. Just a quick disclaimer, Contipo, as she said, is under review at the FDA, and this presentation is based upon the results of our Zeus trial that I'll go through, as well as other publicly available data. Just a few key highlights of Contipo to get us started. It is a new IV antibiotic being considered in the United States with a unique mechanism of action. It has a broad spectrum of in vitro activity, including clinically relevant and increasingly prevalent multi-drug resistant pathogens, including extended spectrum beta-lactamase producing Enterobacteriaceae and carbapenem resistant Enterobacteriaceae. In an era of increased MDR pathogens, there are new agents are needed. And one way that the FDA has recognized this need is by designating Contipo with a qualified infectious disease product designation or QIDP status with fast track review. Again, it has been filed with the FDA, and its PDUFA date is April 30th. So currently there are no ICD-10 PCS codes that describe the administration of Contipo. A unique code would allow would allow us to track the use of Contipo and its related outcomes data. It would also, if NTAP is granted, assist in claims processing and payment adjustments. We have submitted an NTAP application for fiscal year 2020. So both the FDA and CDC recognize the importance of antimicrobial resistance, and the CDC has designated a number of pathogens for which this molecule Contipo is designed to treat, including extended spectrum beta-lactamase producing Enterobacteriaceae and CRE, as both serious and urgent threats to healthcare. These pathogens are associated with high morbidity and mortality, leave clinicians with limited to no effective treatment options, and pose serious threats for hospitalized patients, causing a significant burden to the healthcare system. What's driving this increase is the increase in extended spectrum beta-lactamase producing organisms. So on the left, you'll see a chart that shows the increasing prevalence of these organisms as a function of time. Once you have these organisms, clinicians are then forced to use a class of antibiotics called carbapenems, which are usually reserved for last-line treatment. They have a very broad spectrum of activity. Not surprisingly, once you start using these compounds a little bit more, you see the graph on the right, which is the increase in CRE, or carbapenem-resistant Enterobacteriaceae. So this is just a perpetual cycle of trying to catch up with the pathogens that are causing these infections. This is even more pronounced in the Medicare-eligible population of those greater than or equal to 65 years of age. So this is some data looking at epidemiologic trends by both gender and age. But I want to direct your eyes to the graph on the right, looking at a 5-year trend of data, specifically in age, where there's a very large increase in prevalence in this elderly population and represents a huge unmet need for these resistant infections due to these resistant pathogens. Now, turning specifically to the disease state that Contipo was studied in, complicated urinary tract infections, there's also an increase in hospitalizations associated with complicated urinary tract infections. And of importance is that the urinary tract infections are second only to respiratory infections in rates of hospitalization in those over the age of 65. And in fact, in those patients hospitalized with UTI, 66% are Medicare beneficiaries. Now we'll change gears a little bit and talk a little bit more specifically about fosfomycin. It has a unique mechanism of action. It works like other antibiotics at the cell wall. Those other antibiotics include beta-lactams, which the carbapenem class falls into, as well as glycopeptides. You may be familiar with the drug vancomycin. But what differentiates fosfomycin from those is that it works the first commitment step in cell wall synthesis, while the others work further along in the process. This unique mechanism results in a broad spectrum of activity, able to cover some of these multi-drug resistant pathogens, no cross-resistance with other antibiotic classes, and has demonstrated in vitro synergy or an additive effect in combination with other antimicrobial classes. Contipo is administered as a 6-gram dose every 8 hours, IV infusion for 1 hour in adults with normal renal function. With patients that have a reduced renal function, there are dose adjustments that need to be made, and they're described in the table. ZEUS was the pivotal trial in complicated UTI and acute pyelonephritis. And this study trial design was agreed upon with the FDA. It was a double-blind, randomized, prospective study looking at or comparing fosfomycin 6 grams IV every 8 hours to piperacillin tazobactam, which is really the workhorse in the United States for gram-negative infections, at the highest piperacillin dose that is indicated, 4.5 grams, every 8 hours IV. And the primary endpoint was actually a composite endpoint of both clinical cure and microbiologic eradication at the test of cure, which is around 21 days. The basic ZEUS patient demographics are shown in this table. 2 data points that I think are most interesting for our group is looking at the age greater than or equal to 65. There was about a third of patients fell into that age group in both arms. And then second from the bottom, you'll see SIRS criteria met. And there's about a third of patients in each arm that met this too. So SIRS criteria, SIRS stands for Systemic Inflammatory Response Syndrome, and really kind of correlates well with severity of disease. So about 1/3 of patients met this criteria. Looking a little bit more into the primary endpoint, the overall success in the Contipo-treated patients was about 65%, with about 55% clinical overall success in the piperacillin-tazobactam arm. When you look specifically at a subset analysis of those over the age of 65, which is the pair of bar graphs on your right, you see that these numerical trends continue. What may be more important is trying to really tease out what happened with these patients that either failed or had this microbiologic eradication. So there was a secondary analysis using pulse field gel electrophoresis. Basically, it's genetic testing. And the idea behind this and the goal was to prove that the organism that was present and causing the infection at the beginning for the patient was the same organism isolated in those that were microbiologic eradication or microbiologic eradication failure. And by doing this, we can really kind of track the disease state and really try to pinpoint and look at clinical success. And when you do this, the overall success rate here on the left, you'll notice there's an 11.7% absolute difference, numerically favoring the Contipo arm with a confidence interval that does not cross 0, meaning that it reached statistical significance. And again, these trends continue when you're looking at the elderly population. As with any compound, the safety of patients is of utmost importance, especially in these registrational trials. Both arms saw levels of adverse events that are very typical in registrational trials. Most adverse events were mild to moderate in severity. And when looking specifically at serious events or serious events that cause discontinuation of study drug, there are very few and similar between both arms. Contipo is generally well tolerated in the Medicare-eligible population of greater than or equal to 65. And interestingly, treatment-emergent adverse events were reported in only 12.4% of the elderly population, but 29.6% in the less than 65 years of age population. And why this is interesting is the 29% in the younger population is what you would expect. But usually, in registrational trials, you see higher adverse events in the elderly, and we did not. So this is the last data slide and really emphasizes a key point that I think we all need to understand kind of walking away from this. When you look at the various clinically relevant mechanisms of resistance, so extended spectrum beta-lactamases, aminoglycoside resistance, carbapenem resistance, and then even multi-drug resistance, cure rates in patients treated with Contipo consistently had high clinical success and eradication rates across that subset. So in summary, Contipo is a new IV antibiotic with a differentiated mechanism of action. It addresses pathogens where currently available treatment options cannot. And a unique ICD-10 code would help identify and track the use of Contipo for the treatment of CUTI or acute pyelonephritis and related outcomes data, and is needed to identify qualifying cases if we are granted NTAP. Any questions?
I do have a clinical question.
Sure.
I'm Linda Holtzman from Clarity Coding. Can you speak to how Contipo, thank you, is different from, and I'm going to pronounce this incorrectly also, Vabomere? They seem to be used in very similar circumstances. And I know that there have been issues with identifying Vabomere as well.
So in this setting, I think the easiest way to kind of explain that is while they have in vitro activity against many similar organisms, and they were both studied in complicated UTI, there aren't any studies kind of comparing the two. And because of that, I don't really want to go out on a limb and compare the two clinically. In vitro, data-wise, they do have a similar spectrum of activity, but there are nuanced differences between the two.
Are there any other clinical questions at this time? Okay, for the coding options, they're found on page 34 in the agenda and handouts packet. We'll jump right into option 2, which is to create a new qualifier value in table 3EO. And that's there, so I don't have to read it for you. And then option 3 would be to create a new section X code for new technology. So do we have any questions concerning the coding?
Hi, I'm Candace Blankenship. I'm from Hopkins. I'm a CDI. This is a coding question, and I'm relatively new to the profession, so if it doesn't make sense, accept that as my apology. So my concern is while Contibo will be used in the clinical setting, I don't really code, or I've not seen that we code specifically for antibiotic treatment other than to say that this is a resistant organism to further specify the patient. I think if we take it even a little bit farther for all the people who've come today to ask for a new technology code or another code, is that ICD-10 in the world has the purpose of collecting data for you to use for your clinical studies. In the United States, though, it's used for reimbursement purposes. And we can only submit so many lines of code. And we're already having to use those 25 lines of code for reimbursement, for risk stratification for mortality, for risk stratification for 30-day readmission, for risk stratification for, in Maryland, for MHACs. So when you're asking CDI and coding to code for Contibo to collect data for patient outcome, which as a nurse, I believe is the purpose that this coding profile should serve, but it doesn't here in the United States. So when you ask us to include that in the lines of code that will come to you in order to make these determinations on patient outcomes over the age of 65 here in the United States, what are the chances that's going to make the top 25 lines of code that are going to come to you? That's my concern as we go through this today.
Thank you for your questions and comments, Candace. And I just have to put out the disclaimer that we do not discuss reimbursement or DRG-related issues at this meeting. The purpose of this code proposal, as was stated, is it is related to a new technology add-on payment application, and therefore, according to the statutory criteria, they must have a unique code to identify it.
Are there any other coding questions? Okay, we'll do the nod of head. Option 2, anyone in favor? How many in favor of option 2? You can just nod your head. Option 3? Okay, thank you. Thank you. Okay, our next topic is found in the packet on page 35. It's another new technology request for Xcode for new technology purposes. It's the administration of Zapata, and currently there's no unique code to identify the administration of that drug. They do have a new technology application in place for 2020, and Zapata is FDA approved. Okay. So with that said, our presenter can come up. Sorry, I lost my page, I'm sorry. And we have Dr. John C. Hammonds will be our presenter.
Thank you. Again, my name is John Hammonds. I'm a director of field health economics and outcomes research for Astellas. I am employed by the company who makes the product, and I'm here to speak to you today, and I thank the agency for the time. In our disclaimer, we essentially follow all applicable rules, regulations, and company policies. Overview is exactly as Noel said. There's no unique ICD-10 code for the oral administration of Zapata to treat relapsed or refractory FLT3 mutation positive AML patients, and we seek to have that addition. We did submit an NTAP application for calendar year 2020, and the drug was given fast track designation and was approved on November 28th of 2018. As background, AML is a relatively rare malignancy that accounts for about 1.1% of cancer patients annually. In 2018, there were a little over 19,500 patients expected to be diagnosed. The 5-year survival rate is relatively low, actually extremely low at 26.9%. And of those patients, the FLT3 mutation is one of the most commonly identified. AML, you'll see here to the right, is actually the second most common type of leukemia, second only to chronic lymphocytic leukemia. A few more epidemiological stats. Average age at onset is 68 years, and the average lifetime risk is less than 0.5%. However, with the incidence of 19,500 annually, over half of those patients are expected to die. Patients with AML often relapse or refractory to treatment. Relapse meaning that at one point in time they'd had a remission but have since progressed, or refractory meaning that after their induction therapy or reinduction that they never actually received a remission. Of the 57% of the patients will become relapse or refractory annually, which suggests over 10,000 patients to progress to that point. More than 70% of those patients will then die within 12 months. Relapse refractory AML has limited treatment options. Prior to the introduction of Zospata, the standard of care was salvage chemotherapy, which has limited efficacy, limited survival benefit, and is poorly tolerated. And you see there that 28% of patients in one study reported treatment-related mortality. So much so that the NCCN actually recommends studies instead of actually the salvage chemo in terms of treatment. That was obviously before Zospata was added as a treatment for relapse refractory FLT3 positive AML. Speaking of FLT3, I think I'm going to say FLT3 a lot in this presentation. It is one of the most commonly occurring mutations within AML. AML is a very heterogeneous disease, meaning there are lots of different types of mutations, but you'll see here that according to this statistic, about 37% of the patients will have a FLT3 mutation. And it's just not that simple. There's always a subdivision. So the FLT3 mutations are actually twofold. There's an ITD, internal tandem duplication, and a TKD, which is a tyrosine kinase domain mutation. The ITD mutation confers worse prognosis, and it occurs in more of the patients than the TKD at 30% of the patients. And it confers, again, I said, a worse overall survival and less treatment response. The TKD mutation, which is in less of the patients at 7%, it's unclear as to how that impacts overall survival. In some studies, it's inconclusive. In other studies, it appears to depend more on other genetic aberrations. According to one study, though, the ITD mutation, more than almost 2/3 of those patients will relapse within 5 years. So how does it work? It is a tyrosine kinase inhibitor, which is specific for the FLT3 mutation, and it targets both the ITD and the TKD, or if you're lucky enough to have both, it will target that as well. Prescribing information from our PI, it is a kinase inhibitor indicated for the treatment of patients who have relapsed or refractory AML with FLT3 mutation as detected by an FDA-approved test. It is an oral medication. It's an oral therapy. It's 120 milligrams dosed as 3 40-milligram tablets daily. It can be taken with or without food. Warnings and precautions include PRES, or posterior reversible encephalopathy, in about 1% of the patients. A prolonged QT interval. About 7% of the patients had an increase at baseline of 60 milliseconds or more. Pancreatitis, although it is rare, and embryo-fetal toxicity. The safety of Zospata was actually aggregated from 3 different studies. So there are 292 patients that we evaluated for safety, and they were all treated with 120 milligrams. Median duration of exposure at the interim analysis was 3 months, which ranged from 0.1 months to 42.8 months. A little bit about the study design. The Admiral study, which was our pivotal phase 3, was an open label design because you can't really blind an oral therapy versus an injectable chemotherapy regimen. And it was randomized 2-to-1, 2 gilteritinibs to every 1 salvage chemo. Those patients were then followed up after 30 days and then long-term follow-up every 3 months for 3 years. Study objectives. During the initial readout, we reported out on CR and CRH, which is complete response or complete response with an incomplete hematologic recovery, meaning that you had to have more than 50,000 platelets and more than 500 neutrophils to be a CRH. Good way to remember that is I always think of it as CR half, because a complete response would be greater than 100,000 platelets and greater than 1,000 neutrophils. Also, we looked at overall survival. However, we did not report out on that in the initial interim analysis. Key secondary objectives were event-free survival and then the complete response rate. Patient population, obviously, were patients with FLT3 mutation positive AML. They could be relapsed, however, it was only the first relapse that was allowed, or refractory to their initial treatment. Prior therapy with midostaurin, which is another FLT3 inhibitor, but it is indicated for initial therapy with AML, was allowed. And sorafenib, which is a multi-kinase inhibitor that is often used off-label for FLT3 mutation positive AML, was allowed as well. We excluded certain types of AML like APL and BCR-ABL positive AML. And then from a performance status, the ECOG performance status had to be less than or equal to 2. They had to have baseline liver, kidney, and cardiac function that was acceptable. a baseline QTC interval of less than or equal to 450 milliseconds, no active infection, and no active clinically significant graft versus host disease. This was in adults only. You could have no other active cancers. You couldn't be pregnant, and we did limit some drug-drug interactions unless they were considered essential. So in the interim analysis, which we looked at the gilteritinib-only arm, you'll see that there was 142 patients evaluated. 138 of those patients were confirmed by central lab to have the FLT3 mutation, and then we evaluated the CR and the CRH endpoint. Data cutoff was in August 4th, 2017, and this was truly a global study. 83 sites in 14 countries, America, Europe, Asia, and the rest of the world. So we'll see that reflected in the demographics. Average age was 60, which is a little lower than the average age of onset demographically at 68. It's about a 50-50 split male-female. You'll see here that 60% of the patients were white, 26.4% of the patients were Asian based on the study sites, and about 8% were Black or African American. A vast majority of those patients had a 0 or 1 ECOG score, meaning they're relatively healthy. And the majority of those patients, and this is probably the most important part on the slide, had the ITD mutation alone, which is the one that confers the worst prognosis. TKD alone was a little less than 10%, and both, again, if you were lucky to have both, that was a little less than 5%. Disease characteristics, about 60% of the patients were relapsed, and then 40% of the patients were refractory. We did allow prior stem cell transplant. You see that in about 20% of the patients listed there. And then transfusion dependent. 106 of the patients, or 77% of the patients, were transfusion dependent at the time of enrollment. We'll talk about that a little bit more later. Looking at the interim analysis, you see there was a CR and CRH rate of 21%. CR with complete response or complete remission was 11.6%, and the CRH was 9.4%. So again, remember that these are relapsed refractory patients. The results in those patients are generally pretty poor. We did censor patients at time of stem cell transplant because that can have a treatment effect. We followed them up at a median of 4.6 months, and the median time to first response was 3.6 months. Duration of remission, if you had a complete remission, you obviously had a longer duration of remission. We see that here at 8.6 months. CRH was 2.9 months, and the blended rate of CR and CRH was 4.6 months. Lastly, what I'll talk to you about the transfusion independence. Again, 106 of the patients were transfusion dependent prior to therapy initiation, with 32 patients being transfusion independent. Of the 106 patients that were transfusion dependent, we actually saw about a third of those patients move to transfusion independence. And of the 32 patients that were transfusion independent at baseline, a little over half of those patients remained transfusion independent. So with that, I'll open it up to questions. Thank you.
Do we have any clinical questions?
Yes, I'm Linda Holtzman from Clarity Coding. Can you just speak quickly to, because this is an oral medication, why you need an inpatient hospital code? Is it because the patients are so sick?
Correct.
That the treatment is started in? Okay.
Yeah, the reason you would need it is these patients are generally very ill, and they would sometimes start therapy inpatient. But just to keep in mind, this is oral therapy versus, in the study, the chemotherapy. This is not a combination. It would be one or the other. Thank you.
Do we have any other coding questions? I'm sorry, clinical questions. Okay, so we'll move on to the coding options. They are found on page 36 of the handout. We'll jump into option 2, which is just to create a new qualifier, value V, in table 3E0. And then option 3 would be to create a new code in section X for new technology. CMS recommends option 3, and coders are to continue coding as designated in the current coding at the top of this page. So with that said, anyone in favor of option 2, please nod your head. Option 3? Okay, I see a couple of those. Thank you. Thank you. And I'll be turning this over to Michelle Joshua now.
Good morning, all. The next topic on our agenda can be found on page 37, and that topic is AZEDRA. There is currently no unique ICD-10 PCS code to describe the administration of AZEDRA. This drug is an applicant for new technology add-on payment, and here to present the clinical presentation for AZEDRA is Dr. Daniel Prima. Thank you.
Hi, good morning. Thank you very much for the opportunity to be here. I really appreciate it. So, talking about AZEDRA, the FDA approved this drug on July 30th, 2018. Prior to that, it was granted orphan drug and fast track designation in 2006 and breakthrough therapy designation in 2015. It is the first and only drug approved for the treatment of adult and pediatric patients with pheochromocytoma and paraganglioma, and the label indication includes patients 12 years of age or older with scan-positive, unresectable, locally advanced or metastatic disease requiring systemic anti-cancer therapy. Before this drug approval last July, there were no FDA-approved drug treatment options for this disease. And a new technology add-on payment was submitted for FY 2020. So what is this disease, pheochromocytoma and paraganglioma? Two names just determining the location of origin of the disease, although the disease is largely the same. It's quite rare, with 2 to 8 million patients per 2 to 8 million cases per million patients per year. And the majority of those can undergo curative intent resection, and so only a subset of those patients have advanced disease requiring systemic therapy. These tumors often strike in the prime of life, but can occur at any age. There's a strong familial component to this, with 30 to 50% of patients harboring a germline genetic mutation that predisposes to the disease. Interestingly, there are no molecular or histologic markers on the pathologic specimen of the initial resection that can help determine which patients are at risk for advanced disease. While the primary cause of death in this disease is tumor progression, because these are endocrine cancers that often release hormones like epinephrine and norepinephrine, about 30% of patients actually die from cardiovascular complications from that hormone secretion. In aggressive disease, patients with aggressive disease, survival, 5-year survival is reported as low as 12%, but patients can also have very indolent disease, with some patients having undergone curative resection, presenting with and ultimately dying of advanced disease years or even decades after their initial surgery. And because this is a very rare disease causing very common symptoms, hypertension, arrhythmias, strokes, patients very often have a long period where they go undiagnosed or misdiagnosed, with many patients succumbing before they get the true diagnosis. My personal record is I had a patient who had 4 cardiac arrests before they realized that there might be something else causing it. Luckily, she was resuscitated 4 times. So AZEDRA is a novel radiotherapy product, iobenguin I-131, also called MIBG. It is a high specific activity product that specifically targets neuroendocrine tumors, and we'll talk about the mechanism of action shortly. It is different from the prior MIBG products that had a low specific activity. It is manufactured centrally with a solid-state precursor resin that allows you to manufacture it where the vast majority of the molecules in the formulation are radioactive, whereas with the conventional low specific activity product, the vast majority of the molecules are not radioactive. So in order to give a therapeutic dose, you're giving about 31 milligrams of MIBG molecules, whereas with the high specific activity product, you can give the same radioactive drug dose with only 0.2 milligrams of MIBG molecules. And while the low specific activity product is FDA approved for imaging, it has not been FDA approved as a therapeutic, though it's been used in the past in that capacity as an unapproved drug. Shown another way, if you imagine this vial of MIBG molecules, the red ones are radioactive, the blue ones are not radioactive. And so with the ultratrace process to make the high specific activity product, the vast majority of your molecules, virtually all of them, are radioactive, whereas with the low specific activity product, the vast majority are not radioactive. And the reason that's important is these tumor cells that release catecholamines and many neuroendocrine tumors that don't release catecholamines still express this transporter, the norepinephrine transporter. And what that does is it takes up catecholamines that have been released to help control their function. MIBG is a substrate for the norepinephrine transporter, so it gets taken up into those neuroendocrine tumor cells. and then it can deliver its radiation, causing irreparable damage to the cells. Whether it's radioactive or not, it gets taken up by this norepinephrine transporter, and that is an energy-dependent saturable process. And so if you give an excess amount of unlabeled non-radioactive MIBG, you're actually competing with the radioactive drug, so you can have less of it taken up in the tumor cells. You're also competing for catecholamine reuptake in normal tissues, where you can then cause excess levels of catecholamines during the infusion, leading to chemical toxicity, largely cardiovascular events such as hypertensive crisis that can be life-threatening in many cases. And so it's very difficult to do a clinical trial in such a rare disease and have an endpoint. You can't do a controlled trial with a survival endpoint. And so in consultation with the FDA, it was suggested, because a large percentage of these patients do die of cardiovascular complications from the disease, improving those cardiovascular symptoms is clinical benefit. And so the primary endpoint of this trial was actually the percent of patients who could have at least a 50% reduction in all antihypertensive medicines lasting at least 6 months. And 25% of patients met that primary endpoint, far exceeding the pre-specified efficacy target. And in parallel with that, the more clinically, I guess, interesting endpoint of actually shrinking the tumors was seen in 22% of patients had a RESIST partial response, and the majority of patients actually had some measurable tumor shrinkage. Based on this, there is the FDA approval. The most recent NCCN guidelines also specify high specific activity MIBG, iobenguin, I-131 therapy is the only FDA-approved treatment for these patients. The treatment is given in 2 steps. Because it's a radioactive drug, you can actually first give a small test dose and measure the kinetics within the patient's individual organs, and from that figure out whether your planned dose is likely to be toxic and adjust your dosing regimen. And then that's followed with a planned 2 treatments given at least 90 days apart. Because of the level of radioactive iodine given in these treatments, for regulatory reasons, these must be done in an inpatient setting for radiation safety precautions, and then the patient can be discharged once their radiation levels meet regulatory limits. And all of these radioactive drugs are always, the exact administered amount is documented in the medical record, usually as a radiology procedure, so the exact amount that was administered can be found clearly in the record. And again, I just stress that this is a unique drug product. The high specific activity formulation is different in clinically meaningful ways from low specific activity MIBG, which has never been rigorously tested as a therapeutic in a prospective trial with a clinical benefit endpoint. There is evidence to suggest that the high specific activity compared to the low specific activity may have better safety and efficacy. And it can do that by avoiding the chemical toxicity of large amounts of unlabeled MIBG being given, as is the case in low specific activity, reducing the occurrence of potentially life-threatening or fatal cardiovascular complications. It's a much simpler administration that takes less time, less complications, and it is manufactured centrally under GMP conditions, whereas the low specific activity is often compounded locally, without those quality control improvements that you get from GMP manufacturing. So there are many different names that could be given to this: high specific activity iodine, I-131 iobenguin, Azedra, specifying the dosimetric or the therapeutic dose. I think it's really critically important to differentiate the high specific activity formulation from low specific activity, whereas the radioactive drug may be called MIBG in both cases, but there are medically important reasons to differentiate. And just very briefly, a schema of the study that was the basis largely for the FDA approval. And I will stop there and take any questions.
Thank you. Seeing no questions for Dr. Prima, we will move into the coding options. Coding options for Azedra include creating codes in Table 3E0, by adding qualifier S as in Sierra for iobenguane I-131. The other option would be to create codes in section X, new technology. Any preference for coding option 2? By a show of nods, winks, anything? How about for section X, as this is a new technology? I see heads nodding. Thank you. Okay. We have a question.
Toward the end, you mentioned that the high activity was really important as opposed to the low activity, and that doesn't seem to be reflected in the coding that this is a high activity. That's important to differentiate, because I see right now it's just the name of the drug and then it's the iodine 131. So the name of the drug, does that indicate that it's high?
No, I think, well, if using the trade name Azedra does indicate that it's the high specific activity, but we tend to try to use generic names whenever possible, and I think it is important to include high specific activity as part of the generic designation to avoid confusion.
Okay.
Let me add to that. One other thing to add to that is the high specific activity will be added to the index as well as to the substance key.
Okay.
Okay. Thank you. Do we have any further questions for Azedra? Seeing no questions, I'll turn the podium over to my colleague, Maddie Hugh.
Okay, we're coming into the home stretch. You guys are holding up well. Does anybody need to stand up and stretch out? Seventh inning stretch? Okay, we're on page 40, if you're following along with the packet. We're going to discuss angioplasty with sustained release drug-eluting stent for above-the-knee arteries. And for those of you who were at the September meeting or happen to watch the live broadcast, we discussed a similar proposal, but that was for below-the-knee arteries. So the issue is there is not a unique ICD-10 PCS device value to identify the insertion of a sustained release drug-eluting stent in above-the-knee arteries. And this is related to a new technology application. So I'll turn it over to Dr. Juan Diaz-Cartel.
Thank you very much. And the slides are here. Thank you very much. Good morning. So we're switching a little bit from cancer to peripheral artery disease, which is also very debilitating. It affects almost 10 million Americans, and most of them are in the Medicare age population. That accounts for approximately 6 million patients. It causes claudication, atherosclerotic disease in the leg. It's a narrowing of the arteries by the deposit of atherosclerotic plaque, and patients are not able to walk or walk with high pain, and if the disease progresses, it may lead to amputation of the leg. There are several treatments, endovascular treatments to treat the disease. It goes from balloons to stents, and they are substitutes for bypass surgery, which has a significant level of complications and infections and morbidity. So the main treatment is with balloons, stents, and then later on, drugs were added to those devices in order to improve outcomes. However, every time we put one of those devices in and we balloon the artery or put a scaffolding in the form of a stent, that causes an injury to the artery. And the artery scars. Is like we cut ourselves and there's a scarring in the skin. The same occurs inside the artery. There is an injury and there is a scarring process, which we call the restenotic process. And along with that, there may be also additional deposits of plaque. And this occurs in a prolonged period of time. It's not instant. It's different in different vascular beds. The coronaries behave different than the legs. And in the leg, it's a more delayed process and actually peaks at 12 months. And this is very important to keep in mind because of what I'm going to say next. Eluvia, which is the name of our device, is the first sustained release drug-eluting stent. So as opposed to the other drug-based devices, drug-coated balloons or a drug-coated stent, those devices are sprayed with the drug. This is a more complex formulation. We add a polymer. We're able to use significantly less amount of drug, and we can tune the polymer to release the drug over a prolonged period of time that hopefully matches that restenosis cascade that occurs during months. The Eluvia stent is FDA approved, and the use is for above-the-knee arteries in the superficial femoral artery and proximal popliteal artery. So, as opposed to, as I said, the other devices that are drug-coated, you see the drug tissue concentration over time and the major difference. The drug-coated balloons, once you insert them in the artery and reach the target location, you inflate the balloon, it expands, releases the drug into the vessel, and that's a burst of drug and then disappears generally within 60 days. The same occurs with the drug-coated stent that is currently on the market. Silver PTX is also coated with the drug. You inflate, you release the stent releases the drug, and after 60 days, the drug is gone. With the Eluvia, you put the scaffolding in, and then there is a sustained drug release. The initial curve is much lower, the burst is not so high. We're able to use less drug, but for a prolonged period of time, which again is trying to match the restenosis cascade that occurs and peaks at 12 months. That was in theory. We put that theory to the test with a clinical trial. It's a randomized controlled trial called Imperial, 465 subjects, 2-to-1 randomization, and with the usual safety and efficacy endpoints. We obtain a superior primary patency rate at 1 year over the control, which was this silver drug-coated stent, which doesn't have a polymer and doesn't have a sustained release process for liberating the drug. But perhaps more importantly, that patency number is the target lesion revascularization rate. TLR is basically the rate at which you have to bring the patient back again to the hospital and reintervene in the exact same lesion that you treated previously. And granted, Silver PTX was an improvement over non-coated devices, but this sustained release of the drug during those 12 months allowed us to cut that rate of reinterventions in half, as was proven in this clinical trial, published in The Lancet, by the way. There was also a significant clinical improvement for the patients treated with Eluvia. There was a significant improvement with Silver PTX, but at the expense of twice the number of reinterventions. And very importantly also is to look at the readmission rate at 12 months, which was almost half for Eluvia compared to Silver PTX, and the adverse event related to the device, also substantially lower with the Eluvia drug-eluting stent. We want to reflect also not only the target lesion revascularization, the lesion where you intervened before, but also progression in the vessel, which was also substantially lower, 2.8 versus 7.1%. And as well, procedure and device-related events were lower with this technology. And that's the extent of my presentation. I'll open it for questions.
Do we have any clinical questions? No? Okay. Just hang out up here, please. All right, we're going to go ahead and move into the coding options. We're on page 43 in the handout. So coding option 2 would be to create a device value for intraluminal device sustained release drug-eluting in table 047, dilation of lower arteries. On option 3, page 44 would be to create a new code in section X, table X27, dilation of cardiovascular system, to create new device values to capture the sustained release drug-eluting stent, and it would be applied to the various body part values. And again, this proposal also combines the proposal that was discussed last September, so it addresses those lower knee arteries as well. CMS's recommendation is option 3 at this time to allow that specific level of detail. Do we have any comments or questions for the coding options? Linda?
I'm Linda Holtzman from Clarity Coding. Did anything happen, I don't know if you can speak to this or not, but there was a request at the September meeting to create a new value, body part value for tibioperineal trunk. Is that, I don't know if you can speak to that, but is that wrapped up in this as well?
It was in the September one. I can't really speak to that.
I
but
said I wasn't
it was
sure if you could.
included in that proposal, though.
Okay. So you stated then that this isn't the option 2 and option 3 here are intended to address both what was discussed at the September 2018 meeting and this meeting. Okay,
Yes.
So it's an
yes.
all-in-one. all
Yes,
wrapped
option
up.
2 may not display all the relevant body part values, so.
Okay, thanks.
Yeah.
I need to think about this a bit more, but I just want to express some mild concern about differentiating the proximal and distal popliteal arteries. It creates a profusion of body part values, and if we see it here in section X, which I don't dislike, I'm okay with section X, but if we see it here in section X, I don't think it'll take very long for it to travel over to section 1, and I'm just concerned about the ripple effect on that.
Thank you, Linda. Any other comments or questions at this time? We have one more.
Teresa Rahanic, Intelligent Medical Objects. Just looking at the two, option 2 and option 3. Option 3 contains drug-eluting single, 2, 3, 4, and that is not replicated in option 2. Is there a purpose for not including multiple stents? Are we going to go down that path?
Well, that leads into the discussion that we were going to have today, but we have to push to September, which is regarding capacity within PCS. However, the requested detail was to capture additional stents, so that's why it's replicated here. And again, with Section X, we have the ability to analyze that data in the future to determine if it's absolutely necessary, possibly to incorporate it in the mean section. Any other questions or comments? Okay. By a nod of heads, do we have general support for option 2? Okay, see a couple. Option 3? Okay, a couple. So we'll look forward to your comments, and of course, we encourage you to comment on everything, the coding, the terminology. So thank you very much. Thank you. Okay, we're now on page 45, and we're going to discuss extracorporeal membrane oxygenation, or ECMO, for cardiopulmonary support. There's currently not a unique ICD-10 PCS code to differentiate between the ECMO that is used intraprocedurally for support and is discontinued at the end of a procedure versus the advanced life support ECMO. And there also is not a way to differentiate between peripheral vessel percutaneous and peripheral vessel open cut down, VA and VV ECMO. This is not related to new technology, and I'll go ahead and turn it over to Dr. Joseph Cleveland at this time.
Good morning. I'm Joe Cleveland. I'm an adult cardiac surgeon from the University of Colorado. I'm representing the Society of Thoracic Surgeons. I'm joined by Dr. Jonathan Haft, who's also in the audience, an adult cardiac surgeon at Michigan, who's representing the Extracorporeal Life Support Organization, or ELSO, here. And we're here to talk about extracorporeal membrane oxygenation, or ECMO, for cardiopulmonary insufficiency. My disclosure does not relate to this technology, but I am an investigator for the Momentum 3 study for Abbott Medical. So what is ECMO? Well, ECMO is basically advanced life support. It's used in critically ill patients who are at imminent risk of death from severe heart, lung, or combined heart and lung failure. Essentially, ECMO takes what we use every day in the operating room for conducting cardiac surgery procedures, that is a cardiopulmonary bypass circuit, and it takes to the bedside of a patient. So it replaces the heart and or lung function. It can be maintained sometimes for hours, typically is maintained for days to weeks, sometimes months until organ recovery occurs, transition to some other long-standing organ replacement or a durable ventricular assist device, or death. Essentially, ECMO continuously circulates blood from the body. So blood is taken out of the body to a machine where it receives oxygen and then is returned to the patient. There are two principal modes of ECMO support. The first supports both the heart and the lungs. That's cardiac and respiratory support, and that's called veno-arterial ECMO. If one supports the lungs alone, veno-venous ECMO is used for respiratory support. ECMO can be used in a pre-planned temporary support during a procedure. There has been a slight increase in this, but relative to the number of patients supported on ECMO, this is probably less than 5% of the patients. So, for example, it can be used to support a patient undergoing a lung transplant who has such severe gas exchange that while the donor or while the recipient lungs are being removed and the donor lungs are being sewn in, the patient is supported. It can be used for high-risk percutaneous coronary intervention. It can be used for catheter-based valve procedures. And lastly, it can be used for ventricular tachycardia ablations. On the right-hand side of this slide is a laundry list of indications, including such things as ARDS, aspiration, asthma, post-lung transplant for respiratory failure, cardiac failure typically is for cardiac arrest, pulmonary embolus, drug overdose, post-cardiac surgery as a bridge to transplant, and also to support patients in cardiogenic shock. So I thought I'd show a picture because schematically this makes a little more sense than me kind of waving my hands and saying blood goes here, goes here. So here's depicted a patient. The blue line is a large bore tube that's inserted into the venous circulation. It withdraws blood from the patient to a centrifugal pump. Basically, something that looks like a blender, spins continuously. That pump takes blood then to an oxygenator where gas exchange occurs. So oxygen is placed into the blood, carbon dioxide is removed. It is then returned to the arterial circuit. So this depicts what we call veno-arterial ECMO to the patient. There are various controls to control things like the pump speed. There are various things on the gas exchange side to control oxygen and carbon dioxide removal. So again, to distinguish the two, veno-venous used primarily for respiratory is shown on your right. So again, one large bore tube, and these tubes are typically the size of 18 to 25 French cannula, so large, several millimeters in diameter, withdraws blood from the patient. It goes to a circuit not shown, receives oxygen, and comes back to the right side. So again, this is to support failing lungs. Basically, you can just think of supercharging oxygenated blood to return it to the right side before it goes through the lungs, get the body. On your right side is veno-arterial ECMO. And so that shows, again, blood is withdrawn from a large bore tube from the venous circulation of a patient, taken to the pump, oxygenated, and this time returned to the arterial circulation. And again, this mode of ECMO is used to support both failing heart and lungs. The ECLS registry is a large registry, a voluntary registry that is maintained by ELSO. And so here are data from January 2017 detailing how ECMO is used. And again, there are really three different patient groups: neonatal, pediatric, and adult, as you work down the column from the top to bottom. You can see in the neonatal group, it's used primarily for pulmonary support. So these are typically babies born with things like congenital diaphragmatic hernia, where they don't have a diaphragm and one of their lungs doesn't form properly. You can see the survival for that to discharge or transfer in the far right-hand column is quite good, 73%. Whereas neonates typically are born with a variety of congenital heart defects that are bridged to transplant with ECMO have a much lower support, about 40%. The highest rate of support for ECPR, and that is extended extracorporeal cardiopulmonary bypass, or cardiopulmonary resuscitation rather, for patients that have arrest and then are put on ECMO, is seen in this neonatal group, about 40%. Pediatric patients, it becomes a blend halfway between respiratory and cardiac. Again, this probably mixes a little bit of as we see the pulmonary indications moving away from the congenital things in the neonatal side to much more acquired things, viral infections and other things that kids get. The cardiac is usually, again, kids with adult cardiac, or with congenital cardiac disease that have had operations or awaiting operations, corrective operations in the pediatric time period. For adults, one can see that there are roughly about 25,000 runs of ECMO that occurred, and this is over a long period of time. This is not per year, but this is over a period of time. Again, split a little bit, 66% of these were pulmonary, about 56% were cardiac, and about 40% were extended CPR. You can see the survival for adults undergoing pulmonary ECMO is about 57%, 40% for VA ECMO, that is cardiogenic shock, things like that, and much lower, about 28% for eCPR. So ECMO cannulation, what we're here to talk a little bit more about today in detail, is just describes how do you get basically the blood to leave the body, go to this machine, and return to the body. There are basically, if you will, two overarching different ways to do it, and within one of those it's kind of subdivided. So open central cannulation for ECMO describes ECMO cannulation that is done typically through large incisions, through a sternotomy incision, through a thoracotomy. It's done where the cannulas go directly into the cardiac chambers of the great vessels. Most typically this is done after a cardiac operation that has not gone as expected and somebody needs temporary mechanical circulatory support, and the intent is recovery. Peripheral vessel access is also another way to obtain access to remove blood from the body. That involves either the femoral vessels, cervical vessels, or axillary vessels. And it can be done two ways. One is through an open surgical cut down. Incision is made in the skin overlying the blood vessel. Dissection is carried out down to the blood vessel, and the blood vessel is then accessed in an open fashion to insert the tubes. Growing in popularity is percutaneous ECMO, and that is where, again, with a needle, wire exchange, basically dilating up this skin tract to receive these large bore cannulas, patients can be put on percutaneous ECMO. I would say these are, this is where some of the confusion might lie, because some of the patients that are percutaneously cannulated, you can imagine the reason they're receiving percutaneous cannulation is because they're not stable enough to even move out of the ICU to an operating room or a hybrid room or a cath lab. They're incredibly sick, and so that's one of the advantages of percutaneous. You can put people on within minutes. And that also extends itself for the eCPR group. So it's important to note that it's really the patient-specific anatomic and clinical considerations concerning the peripheral vessels. It has nothing to do with surgeon or provider preference that really determine whether the peripheral access is accomplished percutaneously or via cut down. So things like a very calcified femoral artery or a vein that you're not able to easily pass a wire up would probably lend itself to having an open cut down, versus if wires go up easily, then it would be done percutaneously. Here are some pictures depicting the different methods of cannulation, and for reference, in all these, the patient's, at least in this set, the patient's head is at the bottom of the screen, feet are the top. So on your right side is a schematic showing an arterial cannula inserted directly into the ascending aorta. As you move one cannula over, you'll see the RAC, that is a right atrial cannula. So if you trace the path of blood, it comes out of the right atrium through this one tube, goes to a machine, receives oxygen, comes back in through the AC or arterial cannula. To your immediate right side is actually the picture of that with the arterial cannula inserted in the aorta and a right atrial cannula. The RSPVC cannula is a tube that's inserted in the pulmonary vein to help vent, if you will, the left atrium. So this is open central cannulation. You can see quite an incision. In contrast, percutaneous cannulation, and here shows veno-arterial cannulation, is depicted here. So you can see again on the screen right side is a diagram with a venous cannula on the right patient's right leg that withdraws blood to a pump, receives oxygen, and returns it to an arterial cannula that's inserted in the left common femoral artery. On your right side of the screen is the actual depiction of this. Venous cannula is again on the left side here, withdrawing blood from the common femoral vein. It then goes to a pump, picks up oxygen, and is pumped into the common femoral artery, retrograde into the patient. There's a small RR, which is a return cannula that's in the superficial femoral artery to provide blood flow to the limb. Typically, sometimes these cannulas, as I said, are big enough that that arterial cannula may occlude blood flow to the rest of the leg. And so you provide blood flow down the superficial artery with that small little RR cannula. Here depicts Veno-venous percutaneous cannulation. So again, in the right-hand slide is a veno-venous single internal jugular where actually the cannula has a withdrawal and a return. More typically, though, patients are cannulated with femoral venous access that withdraws blood. It again picks up oxygen and is pumped back into the right atrium. So lastly, in the diagrams is open peripheral cannulation. You can see this is different than peripheral endovascular in the sense that the top left picture shows an incision with a retractor. The fascia over the femoral artery has been dissected, and the femoral artery has been dissected free and isolated in this red vessel loop. In the bottom left is shown actually where sometimes we will actually sew a conduit to the artery, particularly if these arteries are small and we're worried again that the large tube we insert might cause complications, either dissection of the vessel or lack of return of blood flow down the leg. Or if the artery will accumulate a cannula directly, we can place a cannula directly in the artery. Similar for the venous system, you can see the bottom right shows the final product, which is the incision through which you access the vessels, is kind of where the staples are. Beneath that is where the cannulas or the tubes exit. So to sum up, ECMO is most commonly a life-saving measure that can be accomplished via 3 methods of cannulation. And I guess a very central message I want to emphasize is that the method of cannulation has absolutely no bearing on the severity of illness. So to assume that patients who receive peripheral cannulation are less sick is actually often not true. It's often the sickest patients who you can't move out of the ICU that you need to get on quickly that receive peripheral cannulation. The ECMO circuit is either a veno-venous circuit to support respiratory support, commonly for things like influenza, things like that, until patients' lungs recover, or a VA circuit for cardiac and respiratory support. ECMO can be used on a temporary basis for intraprocedural support. And so we think that coding should describe all ECMO cannulation methods and circuits. That is an open central circuit, an open peripheral VA, an open peripheral VV circuit, percutaneous peripheral VA and percutaneous VV ECMO, temporary procedural VA support and VV support. We think that this increased granularity is consistent with the goal of ICD-10 PCS. With that, we'll gladly take questions. Thank you.
Okay, looks like we have a couple clinical questions.
The collection of this, is this going to change the behavior of the selection of the method? What are these data going to be used for? How will they improve patient outcomes in the future?
So I think that the selection of the patients is an overarching theme that I think is universally in the sense that I think what we'll get is more granularity between some of these different groups of patients. I think we will see an increase in this peri-procedural support. How much? Hard to predict. But, we are being asked to place patients on temporary support in the cath lab, come up while they're doing a left main intervention. That's while still sick patient, that's not somebody who's at risk of imminent death within the next hour or so if they don't go on the ECMO. So I think that we'll get some granularity in distinguishing these two patient groups. I think that the codification of this is critical to understand that really it's on the critically ill patients that go on, particularly the peripheral ones, they're very, very ill. And I think that, again, we can understand the central patients who are probably going to be maybe bridged to transplant with the new heart allocation system coming. Will there be more ECMO use? Perhaps. And so I do think we'll gain important outcomes data about tracking these patients. Right now we have the ELSO registry, which is a voluntary registry, and that's all we have.
Okay, I guess I didn't ask that well. Is knowing this information going to improve patient care in the future, or is it going to change patient outcomes? I mean,
absolutely.
You'll be able to identify which one's which, but I mean, okay, never mind.
No, but I think to answer your question, I think there's no doubt that if we can understand if there's a cohort of patients that are perhaps undergoing peripheral cannulation, particularly in the setting of impending shock, that may improve outcomes. Conversely, if we're seeing that the central cannulation patients are doing much worse, then we can understand, okay, is there a way that those patients are being managed, or could they be managed earlier, peripheral cannulation, et cetera. So I do think there's a direct learning that we will obtain from these data that will directly answer your question.
Good morning, thank you. My name's Dr. Jim Kennedy, CDIMD. Can you give me an anatomy lesson and which vessels constitute the central circulation versus the peripheral circulation? Because is the subclavian line, like for example, we call that a central line, you know, so is that central, is that peripheral? Which vessels are central, which vessels are peripheral?
Sure.
Thank you.
I think the central vessels to me would constitute the ascending aorta, the base of the innominate artery, if cannulated in the operating room open through a sternotomy, and that's about it. The axillary artery is peripheral, even though that's a typical central line, but that's a peripheral, as is the femoral artery, as is cervical arteries that are sometimes done in infants, carotid. So central aorta maybe extends to the base innominate, that's it. Thank you.
Thanks very much for a great presentation, Dr. Cleveland. I'm Dr. Scott Maneker. I'm here from the University of Pennsylvania to speak on behalf of both the American Thoracic Society and the American College of Chest Physicians. Both societies strongly, fervently support this application, and with respect to the first question, there is no question in any of the minds of the leadership of the societies and all of the clinical investigators that having very specific codes, as Dr. Cleveland and Elso have outlined for us, will absolutely improve patient care, improve research, and further the ability to provide the right type of support to the right patients. Some real live clinical examples are patients who go on ECMO as a bridge to lung transplant for lung rescue. Some of them do need VA ECMO because they require concomitant cardiac support from either pulmonary hypertension or other intrinsic cardiac disease. Patients with sepsis often require ECMO, sometimes sufficient VV, sometimes requiring VA. Different sets of complications occur with VA. There's really no way to identify the right types of patients, their individual characteristics, and analyze the wealth of data that's been accumulated. Joe didn't show the data on the frequency of ECMO in use over the past 30 years, but in our 30 years experience, the number has gone up exponentially in the past 5 years because of the increasing recognition that ECMO can be a bridge to a variety of life-sustaining therapies like transplant, or a bridge to overcome single organ failure like lung failure. So both of our societies strongly support the development of codes specifically for the various types of ECMO. Thank you.
Thank you.
Thank you for your comments. We're going to go ahead and move into the coding options. On page 46 of your packet, option 2 is to create a new duration value in table 5A1, and the requester had submitted the terminology of intraprocedural, and there was a little bit of misunderstanding, so we are open to the term intraoperative, which is what most of us are used to with PCS, but the intent is to capture ECMO support that is applied during a procedure but is discontinued at the end of the procedure. Option 3 is a little bit more involved. It would be to create a duration value, again, intraprocedural or intraoperative, in table 5A1. And again, the purpose is to capture the ECMO that's performed during a procedure and discontinued at the end. But also, this option includes revising the existing qualifier so that they specify the approach of cannulation, and to create the 2 new qualifier values for the open peripheral and open peripheral venous. So you can see on the top of page 47 what it would look like. And CMS is recommending option 3 at this time, and I don't want to go ahead and read word for word, but we included some rationale, and we know that this is a sensitive issue in past discussions with the open surgical cut-down issue. However, we believe that because this is ECMO and this does not involve a device, and it's pretty much explaining how the circulatory support is being achieved, that we can make this exception, and we believe it's important for the data. So, do we have any comments or questions regarding the coding options? Go ahead, Linda.
I'm Linda Holtzman from Clarity Coding. In the interest of full disclosure, I'd like to note that I have sometimes done consulting with Medtronic and also with Abiomed, and they both have various devices or systems in this space. My issue is strictly with the coding points here. I very respectfully, I read your explanation for why you thought it was okay to use open and percutaneous here, but very respectfully, Maddie, I must oppose the use of the terms open and percutaneous in the qualifiers here in option 3. I really am concerned. We've had a difficult enough time getting people to understand that open and percutaneous, what they mean in Section 1, and I realize this is Section 5, but it's a very short walk from Section 5 to Section 1. And I think that this will cause all kinds of issues among coders, just because of these particular terms. Basically that we've been drilling into people's heads that open refers to being able to look at the target organ, and that's the approach. It doesn't refer to, or we've consistently used percutaneous since the very beginning of ICD-10. We've used percutaneous for any kind of endovascular procedure, regardless of whether it's by cut down or puncture or whatever it is. And there are plenty of devices in just wave me off if I'm going on too much, but there are plenty of devices that are placed through endovascular means, for example, TAVR. And some of those devices are pretty big, and you have to do a cut down. But we've always used percutaneous there. So I just have a real concern. If you feel that it's necessary to make this distinction somehow, let's find some other terminology for it, because this is going to keep me up at night. Which wouldn't be the worst thing that happens here, but I really am concerned about that.
Well, we'll look forward to getting your alternate options for recommendations.
But basically, my feeling here is that CMS should exercise caution in moving forward with this, especially because we're at the spring meeting, and there's a lot of considerations here, and I just don't want to see us back here next year in March talking about ECMO and how we can straighten it out. Two other very quick points. One is, was there any consideration given to, under duration, to using the number of hours? Because there's,
yes.
There's precedent for that.
Yes,
so
there was.
Perhaps in that document that you're going to post, you can talk about why you didn't want to go there.
Yes, that was an option, and we removed it for purposes of this meeting.
Okay.
Yep.
I'll read all about it. I
can put it out there.
Okay. Also, I have heard of some people. I like the idea of identifying when it's intraprocedural, intraoperative, or temporary, whatever we want to call it. But I have heard of some coders who are using a different code for ECMO when it is being done intraoperatively, and I will send that in writing. So
Okay.
that needs to be
Thank you.
factored into. Thank you for listening to all that.
All right. Have another?
Hi, Barb Peterson from Emerson Consultants, and we, of course, work for a number of manufacturers of all these things, too. And I just want to reiterate what Linda said. I think I understand why the procedures, why you want to create them, but from a coding perspective, I, too, am very concerned with putting percutaneous in. The open peripheral one is specifically concerning as far as open to all of us coders means something very different. And so I would just, again, caution CMS to consider these things when it really comes to a coder in a hospital being able to code this correctly. So thank you.
Thank you, Barb. Dr. Kennedy?
Thank you again, Dr. Kennedy, CDIMD. I'm looking at the coding clinic fourth quarter 2015 2000, and let me see which page this is. It's page 26. It does describe central venous catheters as involving the subclavian and such. All I'm asking for is that PCS tell us exactly what these vessels are. If you can maybe write that into the PCS manual so that there's no confusion amongst us, we would be grateful for that.
Thank you for your comments. Okay, are there any more comments? I knew this one would be a doozy. Okay, well, I have to do the usual. Nod of heads. Do we have support for option 2? Blank stares. Okay, option 3. Okay, a couple nods for option 3. All right, well, you've heard it here. We definitely look forward to your comments for this one. We understand the challenges. And Linda, are you getting up again? Okay. All right. We're actually doing pretty good on time, so thank you, everyone. I'm going to go ahead and turn it over to Michelle Joshua.
Okay, we are currently on page 51 of the agenda for endovascular arteriovenous fistula creation with using magnetic guided radiofrequency and venous embolization. There is currently no unique ICD-10 PCS code to describe endovascular arteriovenous fistula creation using magnetic guided radiofrequency energy and venous embolization. This technology is currently not a new technology add-on application, and here to present is Dr. Paul Kryenberg.
Good morning. My name is Paul Kryenberg. I'm a vascular surgeon from Albany, New York, and I appreciate the opportunity to come talk today about the WaveLink endovascular AV fistula procedure. As you know, patients who are on dialysis require some type of AV access as their lifeline because they require a way to remove blood from their body quickly, run it through the dialyzer, and then give it back relatively quickly to keep things from thrombosing. And so because this access becomes their lifeline, now there's several ways to do this. This can be done with a catheter, which is placed into the central veins. It's a large blood pool, can be taken out and given back, but the problem with the catheters long-term is they tend to narrow the veins. There's also a high infection risk. The other way to do it is with an AV graft, which is a prosthetic graft that's sewn between an artery and a vein. Then that's cannulated 3 times a week to do the dialysis, but the problems with the AV grafts is there's a high infection rate. They also tend to thrombose early, so they're not as durable. Given that, the best way to do it is with a native fistula using autogenous vein, where one of the veins in the arm, either the cephalic vein at the wrist or the elbow or the basilic vein, is connected to the artery. Over time, the vein grows, the blood flow increases, and then the needles can be put into that vein to withdraw the blood, run it through the dialyzer, and give it back. Well, that sounds really good, but the problem with creating the AV fistulas is that they do have a relatively high failure rate, and in the literature it runs anywhere between 20 and 60%. The other thing is when these fistulas are created surgically, often they require several interventions to maintain them or mature them so they become usable for dialysis. These procedures are things like surgical revision. It may require balloon angioplasty. It may require branch ligation or superficialization of the vein to move it up to the skin so that they can get the needles in to do the dialysis. But once you get all that done and working, it does become the patient's best lifeline for their dialysis. So as I mentioned, surgical AV fistulas are really the gold standard, but there are several problems. One, the primary failure rate is relatively high. Usually what I tell patients in the office is, about 1/3 of these aren't going to work after I create this, even with the best planning, ultrasound mapping, arterial mapping, and things like that. It does take a while for these to mature as opposed to an AV graft. An AV graft can be used in about a month after it's healed in. An AV fistula takes anywhere between 3 and 9 months to mature. Usually it's 6 months. I'll tell patients if this hasn't matured, we need to move on to a different access. And as I mentioned, they require several interventions to get a working fistula, on average between 2 or 3 in the first year of the fistula to make it workable. And then there is an early occlusion rate of somewhere between 17 and 20%, where patients these will thrombose early, will not be salvageable, then you have to move on to another access. So there's a lot of room for intervention or innovation here to make patients have a usable lifeline for their dialysis. Well, why do the fistulas fail? When when we surgically create these fistulas, what we actually have to do is move a segment of the vein over to the artery, and often they're separated by some distance. So in order to do that, we have to surgically free up that distal end of that vein so we can swing it over to the artery and make the anastomosis between the artery and vein and arterialize that vein. In the process of doing this, it's surgical trauma. That part of the vein basically becomes ischemic, and what happens frequently is this segment becomes stenotic. So when I talk about doing those reinterventions on those surgical fistulas, this is one of the areas that becomes a problem, is that arterial anastomosis. And this is something, once we see this patient back in the office, the flow's low in the fistula, we can then do a fistulogram and angioplasty this area to try to make a usable fistula. Often that's not possible. They may need a surgical revision or abandon this and move on to another access. Well, one of the ways to obviate that swing segment in the vein is not to swing the vein over, but to do this where the veins and arteries are in close apposition and do the procedure percutaneously. And currently there's 2 FDA-approved devices to do this. I'm talking about the Wavelength device today. The other device is the Ellipsis device. And I'm just going to differentiate these two a little bit because they do differ in the technique and also the equipment that's used. The Wavelength device basically is 2 catheters. They're both 6 French catheters. One's placed in the artery, one's placed in the vein. They align usually at the ulnar artery and vein, which is the most common place where we make the fistula. There's magnets in the catheter that align that, and then there's a shoe, and I'll show a picture of this in a second, that then coapts between the artery and vein, and then RF energy is used to create a 4-millimeter hole between the artery and vein. Then that creates the fistula. These are placed through the deep vein, so then we would put an embolization coil in the deep vein on the way out at the end of the procedure before we pull the sheath, and that directs the flow into the superficial veins, which would be cannulated for the dialysis. This is all done under ultrasound guidance for access of the brachial vein and brachial artery just above the elbow, and then we use X-ray fluoroscopy to guide the catheters into position at the ulnar level to create the fistula. The Ellipsis system is a little bit different. It's a single 6 French catheter. This is all done under ultrasound. This is more of an office-based procedure. What this involves under ultrasound guidance is to place a micropuncture needle into the vein at the elbow. It's then directed into the vein, the radial vein, which is next to the radial artery. The needle's then directed into the radial artery, so it's gone through the vein into the artery. And then there's a little anvil on the end of the catheter that then coapts between the artery and vein, and it uses thermal energy to create the anastomosis between the artery and vein. Both procedures have a good technical success rate. The Ellipsis system does require an angioplasty of that where that anastomosis was made at the time of the procedure because there is some narrowing related to the thermal energy that's used. This is just a Wavelength device and a little closer perspective. They did show the radio frequency electrode there, which is that little shoe. So what happens is these 2 catheters are passed percutaneously, so we get micropuncture access in the artery and vein. The sheaths are placed. These devices are then directed under fluoroscopy to the ulnar artery and vein. The magnets then align the radioactive shoe so it's going to touch that foot plate. Once it's all aligned under X-ray, then you fire the RF energy and it creates the AV fistula. The nice thing about this is, if you look at the picture at the bottom, there's no surgical scar here, which does become important when patients go to get cannulated. In the dialysis centers, they're taught to cannulate away from scars at least 2 centimeters, so it would increase the area that's available to cannulate the veins for their dialysis, as opposed to doing an open surgical incision where they would have to stay away from that. So the benefits of this is just a little schematic of this. The fistula would be created where it says endo-AVF there. That's at the ulnar artery and vein. So that would be the site of where the fistula is created. The arterialized veins, the basilic and cephalic on the upper picture there, would be where the needles would be placed for the patients to have their dialysis performed. So the cannulation needles could go in, 2 needles could go in the cephalic vein. You could put 1 in the basilic, 1 in the cephalic, or 2 in the basilic, depending on what the patient's anatomy was. The nice thing about this, it does avoid the open surgery. There's no scarring, would increase the available cannulation sites, and also would maintain other options for fistula creation after this, since there's no surgical scar. So depending on what vein is still available, we could still do surgical fistula creation even after this failed. So these are the potential sites. With a 4 French system, we can cannulate both at the radial artery and ulnar artery. So we could pair up, so if we, in the upper green circle there by the wrist, the catheters could go up in both directions and create a fistula there. We could do it from the ulnar level, or we could come with a vein from the top and the artery from the bottom, kind of in an anti-parallel configuration. But the fistula is always going to be created just below the elbow at the ulnar level or at the radial level. The other thing is when we do surgical fistulas, there is some disfigurement to the arm. Obviously, there's the surgical scars I mentioned earlier where we have to make the incision to expose the vein and artery to sew the anastomosis between the artery and vein. The other thing that can happen long term is pseudoaneurysm formation in the fistula itself. So there is some disfigurement with that. And you can see in the middle picture on the left there how the vein gets very large. The patients get large, kind of dilated, ropey veins, which, basically, they can get caught on things. And I do some surgery on these patients to reduce the size of these because they actually can't even bed their elbow when they get big enough. One of the things that we're seeing with the percutaneous fistulas, they don't seem to develop these long term. So the patient is over a year out on the right there. They don't seem to develop these pseudoaneurysms, so there is some improvement in terms of the cosmesis related to the AV access itself. In terms of the studies that have been done with the wavelength device, there's been the FLEX study, which involved 33 patients, the NEAT study, which was 60 patients, which was a trial run in Canada, Australia, and New Zealand. The EASE study is the trial that was done with the 4 French device and then involved 32 patients. And then there was a post-market study run in the EU, which involved 120 patients. And then the plan is in the US is to run the Connect AV study, which is a large multi-center trial, hoping to enroll between 200 and 300 patients using the wavelength device, which hopefully is going to start relatively soon. So if we look at all the data from that, we can pool all the data from the studies that have been done, the FLEX, NEAT, EASE, and ENDO-AVF EU study, and that gives us a pooled analysis population. And they also have real-world cases where they have data from those which are, because the device is commercially available both in Europe and in Canada. If we look at the technical success rate for the procedure, whether it's in the pooled study population or whether it's in the real-world cases, you can see that it's over 96%. So relatively good procedural success, whether it's in a real-world case or whether it's on trial. If you look at the rate of 2-needle cannulation at 6 months, it's almost 75%, which is also very good compared to the standard dialysis patients that we see. The other thing is they can be cannulated relatively early. In the pooled studies, the median time to cannulation was only 2 months, which is really relatively quick. So the maturation time is relatively rapid. And then the other nice thing is that only less than 20% of the patients on dialysis are using a central catheter at 12 months, which is really the goal, is to dialyze patients with a fistula and not through the central venous catheter. If you look at the overall patencies, cumulative patency is almost 80% with a primary patency of 75%, and this is out just a little bit over a year, which is also very good. The other big thing is with this device, there seems to be fewer procedures that are needed to get a functioning mature fistula. So this is just compared to the USRDS database, so it's a surgical cohort of fistulas that were created, and you can see that 1 month after the fistula was created, only about half the surgical AVF patients need an additional intervention, compared to only 15% of the patients who had a percutaneous endovascular fistula created. And at a year, about 85% of the surgical AVF patients are going to have had an additional intervention, compared to only about 38% of the endo-AVF patients. So fewer procedures that are needed that are required to create a functioning mature fistula. This is just kind of sums it all up. If you look at all the interventions that are required, both interventions on the access circuit itself, central line placement, or whether the patients need to be treated for infection, really, it's almost 6 times fewer procedures that are required in the patients who had an endo-AVF as compared to those that had a surgical fistula. And that, again, this is from a propensity score match Medicare cohort of surgical AV fistulas. Big thing though, if you look at patient satisfaction, this was a questionnaire that was done by Charmaine Locke. Patients are really satisfied with the endo-AVF. So, are they satisfied? Yeah, it's over 95%. Would they change anything? Less than 16%. Would they recommend it? Almost 3/4. So really, in terms of patient satisfaction, it really meets their needs because they don't have to have surgery and they get a functioning fistula out of it. This is just from a survey that was done by the American Association of Kidney Patients. And if those patients are surveyed, what really matters to dialysis patients is what's the risk of infection with the procedure? Do the doctor recommend it? What's the durability? The risk of needing another procedure, because you're talking about a patient population that's already tied down 3 days a week, 3 to 4 hours, getting their dialysis, and then you're going to ask them to come for additional procedures to maintain their fistula. It becomes very important to them if they don't have to have secondary procedures. And then what is their impact on daily activities? And then if you look at why patients won't go and have a fistula, one is because they don't want to have an invasive procedure, and then they're also concerned about the durability. So they want things that are going to last, that can be done minimally invasively. So, and in summary from this, then 86% of patients without an AVF would have been more likely to get an AVF if there was a less invasive option available. So I just want to, I guess, okay, we'll wrap up. I kind of went through that anyway. Okay, we're all set. So I'll be happy to take any questions.
Thank you, Dr. Kryenberg. We'll move into the coding options then. We have one option available for the creation of new codes, and that involves adding the approach value percutaneous to table 031 with a root operation of bypass of upper arteries to the ulnar and radial artery body parts with a device value of no device. CMS is recommending option 2. By a show of heads, nods, winks, yays or nays. Okay, I'm seeing some. Any questions regarding the coding option? I think we have a question.
I was interested to see that the only change that's being proposed here is to add the percutaneous approach value, which I like very much, and I certainly agree.
Great. Thank you.
Because that's the only change, this would then make it possible for the other percutaneous system, which, can I say your competitor's name here? Is that all right? Yep. There's Ellipsis by Avenue, I think? Yep. Right. I'm not associated with any of those groups. Okay. So they could use the same code, which, you know, is that seems, you know, perfectly reasonable to me. I just wanted to ask, are there ever any situations where you have to balloon the newly created anastomosis at the same time, you know, right after it's created? Are you ballooning it at any time? Because that could complicate the coding.
Yeah, for the Avenue system, they do balloon it at the time of the index procedure. For the WaveLink device, no. That's not done at the time of the index procedure.
Okay, thank you. I appreciate it.
Thank you again, Dr. Kryenberg, and thank you, Linda, for your comment and question. Any additional comments or questions? Thank you. Okay. Seeing none, we will move on to the next topic in our packet, and that is that of the administration of Jakafi. That can be found on page 48. Currently, there is no ICD-10 PCS code to describe the administration of Jakafi or ruxolitinib. This drug is a new technology add-on payment application, and here to present the administration of Jakafi is Dr. Ahmad Naeem. Thank you and welcome.
Thank you very much. Okay. So Jakafi or ruxolitinib was first approved in 2011 for the treatment of high-risk myelofibrosis, and also in December of 2014 for treatments for patients with polycythemia vera who've had an inadequate response to hydroxyurea. It's an oral medication. It's a Janus kinase that blocks JAK1, JAK2 signaling. It's available in multiple formulations, which allows the healthcare professional to tailor for the approved indications various different schedules and strengths. So it's currently under an investigational use for the treatment of acute graft versus host disease. I'll touch upon that in a little while. And the indication that we have submitted the supplemental NDA for is for patients with acute graft-versus-host disease that is inadequate responding to corticosteroids. So we have an orphan drug indication and also breakthrough designation for that. FDA accepted our filing, and we are under priority review with an extension date of May 24th of this year. So a little bit about graft-versus-host disease. It's a complication, or one of the major complications of allogeneic stem cell transplant. And about 9,000 of these transplants are conducted in the U.S. every year for various hematologic malignancies. Acute GVHD, approximately 3,600 of those 9,000 cases is observed, and off of those, about 1,500 or so patients are deemed to be steroid refractory or the inadequately responding patients. A couple of additional points are important to outline. The disease can be diagnosed while the patients are in the hospital for the initial post-transplant care. This is about 30% of the patients, and 70% of the patients will be diagnosed outside of the hospital after their initial discharge post-transplant. The patients that are diagnosed in the outpatient setting, approximately 40% of those patients will be readmitted for their care of acute GVHD. The dosing for Jakafi that is being suggested in acute graft-versus-host disease is 5 milligrams twice daily. That can be raised to 10 milligrams twice daily if needed. And those are the only two doses that are being recommended for graft-versus-host disease. As I mentioned, about 40% of those patients that do get steroid refractory disease will be readmitted to the hospital. So even though the treatment may start in the outpatient setting, the inpatient setting would also be significant. So there's an ICD-10 code for acute disease, 89.810. And if the evidence for the inpatient utilization of Jakafi can be found in EMRs, progress notes, or charge masters. So as Michelle mentioned, there is no PCS code right now, and we have an NTAP application. So just a little bit on the what is the clinical issue with graft-versus-host disease. As I mentioned, patients who are undergoing stem cell transplant will get this complication. It's a very serious complication where it's a very high risk of mortality, certainly very, very high morbidity. I'll share some data as to what that looks like. Corticosteroids are used as a first-line treatment for almost all of these patients. The disease does go from grade 1 to grade 4, where 2 to 4 is systemic treatment. About half of these patients at some point will not respond optimally to corticosteroids. Once that happens, the disease is much more severe. In the inadequately responding patients, almost 60 to 80% of these patients will die in a short amount of time. At this time, there are no approved treatments in the steroid refractory or second-line treatment for graft-versus-host disease. So this is just a survival curve showing the two populations, the steroid responsive and the steroid refractory. As you can see, both the decline in sort of survival is very significant in the first year post-transplant, with the red line almost touching 80%. So only 20% of patients will be alive at 1 year with the steroid refractory disease. So certainly a very grave complication of acute graft-versus-host disease. So real quick, we are currently investigating, I think I may have skipped, no. Under a pivotal trial, so I just wanted to mention how Jakafi works. So graft-versus-host disease develops when certain types of cells from the donor attack the body because they recognize certain parts of the body, the skin, the gut, other organs as antigen or foreign tissue. So the way this works is there are certain signals that are sent through some cytokines, and ruxolitinib blocks those cytokines, and downstream those cells are redirected to the sites of the leukemia rather than to the organ damage. So that's primarily how it works. So this is just I don't want to go into too much detail, but this is our first prospective pivotal trial of ruxolitinib in the steroid refractory space. As I mentioned, there are no other treatments available. So this study is currently read out and a positive study. So just a quick on patient demographics, 58 years of age, and most commonly used graft source is peripheral blood, which is how most of these transplants are conducted in the U.S., and two main diseases, which is acute myeloid leukemia and myelodysplastic syndrome, are the primary reasons why patients undergo these transplants. Baseline characteristics in our study of 71 patients that we enrolled, two-thirds of the patients are around grade 3 to 4, which is a much more severe form of disease. Other things that are important to remember are the CMV or cytomegalovirus rate for both the donor and the recipient, as well as certain steroid refractory criteria that are mentioned here. Looking at the primary endpoint, which was day 28, overall response rate, just to direct your attention to the lower right blue box in the table, and that's at 59%. So the study is considered positive. And day 28 endpoint is used in many clinical trials in graft versus host disease because it's been shown to be a surrogate outcome for, or a predictive outcome, I should say, for long-term survival and other outcomes. Another important thing that we observed in the study was an overall response rate of 72.3%, which is quite notable. The response, I should say, is defined by three things: complete response, very good partial response, and partial response. And complete response, as it states, is the disease is completely resolved. Every organ and every manifestation of the disease is gone. Very good partial response is very close to complete response, and partial response is where one organ may be completely resolved, or two organs, and maybe one organ is at a lower rate. So complete response is ideal. So if you look at the bottom bullet, more than half of the patients achieved a complete response, which, if you recall by the curve that I showed you, in any of the steroid refractory other treatments, that has never been observed. So responses were observed irrespective of the steroid refractory criteria. Not to go into too much detail, but there are various different definitions and in clinical research are utilized to describe how a patient may be not responding adequately to steroids. So we just wanted to break the data down. So if you look through the, again, the yellow, the blue row here, you'll see all the responses that are provided. So they range from 63%, 46 to 63% in various different definitions of steroid refractory. It's a very busy slide, so apologies for that, but the reason here to show that how quickly, one of the questions that gets asked is, how quickly is it Jakafi is able to resolve the disease, and which organs does it affect? So just in the middle of your slide on the left-hand side, 63% of the patients saw very good responses with one organ involved, and 41% with two or more organs involved. And the box at the bottom here, the green box, just shows various different organs that are involved, and it shows that ruxolitinib was able to have responses in all different stages with all different organs. Duration of response is also very important because it's indicative of long-term outcomes. We saw in the study, we saw the median time to first response, which is very important since these patients are very sick, was as early as 7 days. With the median duration of that response, meaning that if you saw any type of partial, very good partial, or complete response, you were able to maintain that response up to 345 days. Event probability estimates, which basically means that you're not having any other event, at the 3-month time or duration of treatment of 3 months was almost at 82%, and at 6 months, that's 65.2%. So this is just the survival curve, and it shows 3 different subgroups. The green are the initial responding patients. The blue are the other responders, the patients that may have responded after 28 days. And the non-responders are sort of in that dark gray line. So it's self-explanatory. The patients in the green trend line are doing much better, with the 12-month probability of survival at 66.2% as compared to the charcoal line, which is at 10.5%. So majority of patients were able to also reduce their steroid dose. It's also an important endpoint to manage. Looking at safety, this is the on-treatment adverse events among 20% or greater patients, and no additional safety signals were observed given this population that experienced these irrespective of treatment. Infections are also important to note. So these are various different infections, and again, it's very consistent with this patient population, and no additional safety concerns were observed for ruxolitinib. CMV events, similar story, not to go into too much detail, but it's relatively low observed events, and various different definitions of CMV positive, or going from all the way from infection to viremia. So in summary, in this first prospective trial of acute GVHD, Jakafi treatment was able to show responses of 54.9% at day 28, and many of those responses were grade 3 and 4 disease responding patients as well. The best overall response was 73.2%. Responses were rapid and durable with a median time of 7 days. And most patients sustained reductions in corticosteroid. As I mentioned, that's also important. And relapse from the original malignancy was also very low at 5.6%. And the conclusion is that Jakafi is well tolerated, and the adverse event profile, as I showed you, is very similar to this particular patient population for steroid-refractory acute GVHD disease. And that's it. Thank you. Any questions?
Thank you, Dr. Naeem. We have two creation of new coding options to consider. Option 2 would be to create new qualifier value T for ruxolitinib in Table 3E0. The other option to consider is the creation of a code in Section X. CMS is recommending to create codes in Section X. And I see nods already for the Section X, so thank you so much. Do we have any questions regarding coding options for ruxolitinib or Jakafi? Seeing none, we will move on to the next topic, and thank you again, Dr. Naeem. The next topic can be found in your agenda packet on page 55. This topic is T2 bacteria panel. There is currently no unique ICD-10 PCS code to identify or describe the T2 bacteria panel. This T2 bacteria panel is a candidate for new technology add-on payment for fiscal year 2020, and here to discuss the T2 bacteria panel is Mr. Tom Lowry. Welcome.
Thank you, Michelle. I recognize I'm the last one, so I appreciate everyone's patience, and hopefully it's worth your wait. So the T2 bacteria panel is positioned to help address the problem with sepsis and bloodstream infections. Today in the United States, sepsis is the most expensive hospital-acquired infection and condition. Over $20 billion are spent, and about a third of inpatient deaths are attributable to bacteremia and sepsis. It's a major problem, and for that reason, antibiotics are used very aggressively to help address the risk of bloodstream infection and sepsis. And T2 bacteria is positioned to help address that problem by helping inform antibiotic decisions earlier in the progression of disease. Today, almost half of patients who are on empiric antibiotic therapy are not on the effective therapy. And that's a huge problem due to how the odds of death and the risk of mortality depend on the time it takes to get on appropriate antibiotic therapy. Species-directed therapy, that is when you know that there is a pathogen infecting the patient and you know the type of pathogen, increases the odds of effective therapy dramatically, where patients are then, 95% of patients are on effective therapy. So that's a tremendous opportunity that we need to take advantage of to help improve patient care. The T2 bacteria panel is a panel, the first of its type. It's been FDA cleared that identifies 5 pathogens that are highly prevalent in bloodstream infections. Depending on the epidemiology of the patient population, hospital covers between half and almost 3/4 of bloodstream infections experienced in our hospitals today. And so this represents a tremendous opportunity to have a big impact on a big problem that we face across our country. As I've mentioned, a major predictor of outcome is getting patients on effective therapy early. I'm going to take you through a few examples of that. And also, one of the side effects of this problem that we face today is the unnecessary use of antimicrobials and exposing patients to antimicrobials that they don't need, which can contribute to the spread of resistance. So the concept of the T2 bacteria panel and the way it gets used is it's run from a EDTA blood vacutainer that's taken from the patient and then loaded directly on the T2Dx instrument. Today, the standard of care is drawing multiple blood cultures and then waiting for those cultures to come positive, and then when they come positive, identifying the pathogen that's present. So as I mentioned, T2 bacteria has been cleared by the FDA. There is no existing ICD-10 PCS code. That's why I'm here before you today, and we have applied for an NTAP. Just a little review of the clinical context so that you can be familiar with how the test is being used. Today, the decisions on antimicrobial therapy and the bloodstream infection diagnostic process are very interrelated. So because of the time delay it takes to get a positive blood culture, patients are subjected to empiric therapy. And empiric therapy is typically based on an educated guess of what the epidemiology of the hospital is, the type of patient condition, and the patient's history of infection. Once the blood culture comes up positive and identifies a species, then that information is used to do what is called species-directed therapy, which greatly increases the likelihood that a patient is on effective therapy, going from about 50% likelihood to about 90-95% likelihood. And then once that isolate has been characterized for susceptibility and that resistance information is available, then that information then helps close the gap and get patients on the exact correct therapy. So this delay that it takes to know if your patient is infected and then know what the patient is affected with plays a very important role in driving the mortality rates of sepsis. One of the striking things is that in the patients that are at risk for bloodstream infections today, you have about a blood culture positivity rate of about 10%. However, in that same patient population, the use of antimicrobials is in the range of 50 to 70%. And this is because everyone knows that getting patient on effective therapy is very critical for their survival. So if you have a bloodstream infection, the odds of death for that patient increase by 4% for every hour that the patient's not on effective therapy. If the patient progresses to septic shock, then that increase for every hour goes up to about 7.5%. And so moving the information, available information earlier in the progression of disease presents an opportunity to help impact the outcomes and the length of stay of these patients, as well as help to impact the appropriate use of antimicrobials. So the T2Dx instrument, the T2 bacteria panel were cleared this last summer. To be clear, T2Dx instrument was cleared several years ago for a different panel. T2 bacteria was cleared this last summer. It's a CLIA moderately complex assay that can be used in a standard clinical laboratory in the hospital. There's an image of the cartridge with the tube of blood on it that's getting loaded on the instrument. So when you have a T2-based detection platform in your treatment routine for patients, that provides information for species-directed therapy far earlier to help confirm that, yes, you do indeed have an infection and you know if it's one of the pathogens that are on the T2 bacteria panel. And that presents a lot of new antibiotic stewardship and also patient treatment algorithms to a hospital to allow them to determine how best to impact their patient care in their hospital with a technology like the T2 bacteria panel. The T2 bacteria pathogens are really designed based on what are known as the escape pathogens. One could call the panel the T2 escape panel. You may wonder why they're called the escape pathogens. These have been presented in the literature as the pathogens that are most likely to escape standard antimicrobial therapy. And they're shown here on this. So the bacteria panel covers about 90% of the bloodstream infections caused by escape pathogens. And as I mentioned earlier, it covers between 50 and 70% of all bloodstream infections. We've done a pivotal study. I know I'm the last speaker, so I won't take you through all the details of it, but it's a multi-center study. And from that study, looking at that data, we can look at how the T2 bacteria panel could have affected therapy choices in these patients. I'm just going to take you through the highlights here and then can answer questions as necessary. The first takeaway is the time to results. The time to species ID for this panel on average for the study was 5 hours, as compared to the standard of care in these hospitals was 3 days. So that represents a significant time saving to getting this piece of information about whether or not your patient's infected with one of these pathogens. The other dimension here is evaluating the antibiotics that the patients were on. Was really striking, that despite the heavy use of empiric antimicrobial therapy in this patient population, there was a significant opportunity to positively impact the patients who were positive by T2 bacteria. So 70% of the patients could have had an adjustment in therapy that would have been a positive impact in their care. Half of the patients would have actually benefited from species-directed therapy to get them on effective therapy, and that would have had a significant impact on their mortality. And based on the data here, I'm showing some charts that shows the time savings for these different categories of therapy changes that were available for these patients. Other literature has demonstrated that there's significant length of stay reduction available when you get patients on effective therapy far earlier. The other dimension here is, of course, stewardship and appropriate use of antimicrobials. For the patients in the trial that were positive by the panel, a significant number of those patients could have had, on average, 3.5 antibiotics withheld because they were shown to be infected with a specific organism that would have merited escalation and very specific treatment. Other studies have also looked at this, showing that there's significant opportunity for stewardship interventions. And then lastly, all these interventions add up to the opportunity to be able to positively impact outcomes and length of stay. And so we're really excited about the opportunity to work with CMS on the possibility for an NTAP criteria. There are some common questions with this type of test. So where is the result reported? The result would be reported in laboratory orders. It also could be in progress notes from various groups within the hospital. The test is called T2 Bacteria Panel. Typically, that's how people name it. We do have another panel called T2 Canada Panel, and so you definitely need to be looking for the words T2 and bacteria for looking for the use of the test. So just to summarize, we're requesting a unique code for T2 bacteria. It represents an opportunity to significantly impact patient care for patients suffering from bloodstream infections and sepsis. We do have FDA clearance, and there is no currently available code. So thank you for your attention. I'd be happy to take any clinical questions.
Okay, seeing no questions in the audience, we will move on to the coding options for the T2 bacteria panel. We have 2 options for consideration of creation of new codes. The first would be to create codes in table 4A0 using the 6th character function value J for infection and new qualifier value M, whole blood nucleic acid base microbial detection. The other option to consider is creating new codes in section X, new technology. CMS is recommending the creation of new codes in the section X for new technology. By show of smiles, I already see one, but I also see a question, so we'll take a question.
Sue Bowman from AHEMA. I have a lot of concerns about this proposal. First of all, we don't generally code lab tests in PCS, and it's a bad precedent. We're going down, I think, even more so than the drugs. And to sound like a purist here, but I'm not really sure this definition, Nellie and I were just having a sidebar on this, really fits this. It's not really determining the level of a physiological or physical function. I just don't see how this even really fits in this structure of PCS.
Thank you for your comment. Well, we went through the options for this one. If we were in a paper and pencil world, you would come into our respective offices and see lots of crumpled up paper thrown in trash cans. Remember those days? We did consider these coding options very carefully, and we were most interested, and still are, in comments here from our expert coders. We have another question.
It's actually a comment. Nellie Leon, she's saying, I share Sue's concern because we don't code test results, and if for those of us who have been around before ICD-10 PCS was implemented, there was a whole section for laboratory testing that got tossed out, which is why it doesn't really fit an existing root operation, an existing box within PCS, because we got rid of those. But I guess, I do recognize the clinical value of identifying sepsis quickly so you can start treatment. But similar to other comments before, perhaps there could be some coordination between the coding requests and the NTAP process, because I have never seen an NTAP application for a test being approved. And I would hate to create a precedent to create a code for a lab test that then may not get approval for the add-on payment. And I realize that, on the one hand, we say, well, this is not a reimbursement committee. At the same time, we are entertaining proposals and approving codes that fit into a payment system. And this just doesn't seem to fit even the structure of the codes or the definitions of the root operations, which we've learned from the beginning that the most important thing for a coder to understand to apply PCS is to understand the objective of the root operations, the definitions of the root operations, and apply them very carefully and following them to the word. Thank you.
Thank you for your comment.
It's my understanding with laboratory data that a lot of it is collected through SNOMED, and that they only put a code on it if they're going to send it out and bill it. So if it's done internally during the hospitalization, then it's you usually that's in a different. It's collected in a different part of the record, and you usually don't see those kinds of things. So having to start looking for labs, and it's been so easy when you're training people on PCS to say, don't worry about lab. It's been, and so starting to collect this here is going to be a bit of an issue with trying to get. People have been taught over and over, labs are not part of PCS.
Thank you for your comment. Do we have additional comments in the auditorium? Okay, seeing none, thank you, Mr. Lowry. This concludes the presentation portion of our meeting today, and I'll turn the podium over to my colleague, Maddie Hugh.
I just want to thank everyone, the clinical presenters, the participants, and the analysts for hanging in there with us today. We hope that nobody felt overly rushed. I do want to announce that we do plan to post an updated agenda and handout packet. So we will include that alternate option that we referenced before for ECMO with the duration values, and we will also address Nellie's comment regarding brachytherapy in that. And lastly, we're going to revise the order appropriately to reflect the Jacobite page numbers. We will be having 2 topics tomorrow related to the procedure codes, and so thank you, Donna, for accommodating us. We'll have a remote presenter for Noelle, one of her topics, and then also we will hear Rhonda Butler over the phone, who will review the addenda as usual. Tomorrow, we will be in the media center, not this room, so everybody pass the media center on their way in here. And that will be for the diagnosis topics, which will be a full day tomorrow. Yeah. We cannot use this room tomorrow, so it's in the packet, but that's why I'm announcing it in case people didn't read or they just overlooked it. So yes, tomorrow's the media center. I'll be stationed out there to direct you to the correct room. And then lastly, the cafeteria is still open for those of you who are starving who want to grab a snack. And again, thank you, everybody, for hanging in there today. This concludes the PCS topics.